Good morning, everyone. Welcome to the 2022 World Obesity Day Summit, and thank you for joining us. My name is Leah Wiggum, and I'm the Director of the Center for Community Health Impact and Associate Professor at the University of Texas Health Science Center at Houston School of Public Health in the Department of Health Promotion and Behavioral Sciences in El Paso, Texas. I'm also the co-chair of Live Smart Texas. Before we get started, I'd like to take care of a few housekeeping announcements. This webinar is being recorded and will be archived along with the presentation slides at our website, msdcenter.org. If you signed up for the webinar, you will get an email notifying you when the webinar is available. If you have any questions during the presentation, please enter them into your questions box. We'll have time for Q&A at the end of the presentation. Today's webinar is hosted by the Michael and Susan Dell Center for Healthy Living at the UT Health School of Public Health in Austin in partnership with Live Smart Texas. Next slide, please. Live Smart Texas is a coalition of organizations and individuals who work together to address the state's obesity epidemic. As you can see here, our co-chairs are myself and Dr. Emily Durander, and we will be facilitating the webinar today. Next slide, please. Obesity is a complex disease with a multitude of causes and contributing factors. The causes of obesity are rooted in the body's dysregulation of energy storage. Next slide, please. This dysregulation leads to excess fat storage. In other words, obesity is caused by an inability of the body to maintain fat storage in a healthy range. In our world today, there are also a multitude of contributors to obesity. Next slide, please. These include many environmental and social contributors that can interact with the causes within an individual to make maintenance of a healthy body weight even more challenging. To address obesity, we must act on both the causes and the contributors. Importantly, we must not blame the individuals affected by this disease, but instead work together to find solutions. Next slide, please. On World Obesity Day, we come together to recognize that to tackle this extremely complex disease, we must all come together and act. Next slide, please. We have a lot in store for today's summit. We will hear from our keynote speaker, Ted Kyle, with ConscienHealth. Following the keynote, we will have the LST Live Smart Texas Steering Committee members, both regional and organizational representatives, provide quick updates about events happening in their areas. Then we will learn about the state of obesity in Texas, presented by the Partnership for Healthy Texas, featuring a panel of experts. And lastly, Dr. Deanna Hoelscher, Regional Dean at the UT Health School of Public Health in Austin, will close out the day with a presentation titled Texas School Physical Activity and Nutrition Texas SPAN Survey, Translating State-Level Obesity Data into Public Health Impact. I am so excited and honored to be able to introduce our keynote speaker today, Mr. Ted Kyle, founder of ConscienHealth, who will share his talk entitled Obesity is Not What We Thought It Was, So Where Do We Go From Here? Ted is a healthcare professional experienced in collaborating with leading health and obesity experts for sound policy and innovation to address health needs and the obesity epidemic in North America. For the past 10 years, Ted has dedicated his career to understanding how to address health issues and needs created by obesity. In 2009, Ted founded ConscienHealth to help experts and organizations work for evidence-based approaches to health and obesity. Through ConscienHealth, Ted works to advance changes in policy and public opinion that will allow new approaches to be developed and put into use. I consider Ted a very valuable friend and colleague. He's a giant and leader in the field of obesity. We are very lucky to have him here with us today. So please welcome me and please join me in welcoming Ted Kyle. Ted, I'll turn it over to you.
Thank you so much, Leah, and I am so grateful to be here, so honored that you would invite me and give me the chance to speak. So I'm going to talk a little bit about what do we do with what we thought obesity was, and how it has surprised us, and what we can do about that. So next slide, please. These are my disclosures, professional fees from these organizations, as well as some personal biases that I have, which I think are relevant as you think about, where is this guy coming from? Next slide, please. I really have 4 objectives for what I want to talk about today. I want to talk about our history in trying to address the obesity epidemic, the challenge that prevailing bias creates for doing that, some indications that we are indeed making some progress, and I want to describe a pathway that we might follow to find more success. Next slide, please. So starting with that brief history, next. I just want to say we have 4 decades of relentlessly rising obesity, and I've been watching it for actually quite a while. I've really devoted my professional career to this field for now 2 decades, and all that while obesity prevalence has been going up. Every now and then I've heard from people saying, we've got this, and it turns out, no, we don't. Next slide, please. Back in the 70s, this editorial in Lancet said, you know, this really isn't so hard. If we would take care and make better choices, we could prevent most obesity. That has proved not to be true. Next slide. In the 80s came the rise of the advocacy for low-fat diets as the answer to our problems with obesity. The unique merits of low-fat diets for weight control, and so we had low-fat everything, including devil's food cookies. Next slide. In the 1990s, late, we had clinical guidelines for treatment of obesity and overweight, as those low-fat dietary recommendations seem not to be helping us terribly in reducing the prevalence of obesity. Next slide, please. So as people started to realize that those low-fat diets weren't serving us well, then we thought we'd give low-carb diets a spin, and interesting data and some good results for some people. But that, in retrospect, did not turn out to be the answer to all of our problems. Next slide, please. Along came the Obamas, who said, you know what? We are going to solve the problem of childhood obesity within a generation. And lots of good ideas, lots of good energy, but not a real bending of the curve as everyone expected. Next slide, please. Now it seems that we're turning to plant-based diets. Also a very good idea for many good reasons. And the promise is that these plant-based diets will both reduce obesity and help to save the planet, kind of a 2-for-1 deal. Next slide. If you look at the literature that's coming out about this, you can find some really impressive big promises for what plant-based diets can do. However, empiric evidence to say, yep, at a population level it is going to have these effects might be a little scarce. Next slide, please. One thing we do know from looking at the prevalence data on obesity and overweight is that we have seemed to approach the limits of the population that is susceptible to weight gain beyond what we used to call a normal BMI, a BMI less than 25 and over 18.5. And so it does look like the prevalence of BMI less than 25 is going to kind of bottom out at around 25% of the population. Next slide, please. However, what we do see is that severe obesity and obesity are still growing in the population. So those folks who are susceptible susceptible, the 75% of the population that seems to be susceptible to weight gain in our current environment, are progressing from overweight to obesity to severe obesity. And if you look at the data from this paper that was published recently in the New England Journal of Medicine, you can see, next slide, that the prevalence has grown from 1990 to 2000. Next slide. To 2010. Next slide. To 2020. Next slide. And by 2030, the expectation is that obesity prevalence will reach 50% worse. Next slide. We can expect that the prevalence of severe obesity, which is growing at the fastest rate, will reach 25% of the population. This is going to have really serious implications for population health. Next slide. So, why has progress been so elusive? That's the real question that I want to take on. And I have a supposition about this. On the next slide, I'm really here to tell you that it's all about the challenge of bias. Yes, this is a complex problem. Yes, there's a lot going on, but at the root of a lot of the problems that we have, you will find bias where people say, I know what this is, I know what will work, and we just need to work harder at what we're already doing. Next slide. When I say bias, there are lots of ways that you can think about bias. Bias is certainly an important concept in statistics and quantitative methods, but the bias that I'm talking about is all about that human inclination to hold on to a partial perspective and refuse to consider the merits of other ways of looking at a problem or a situation. Bias can be against an individual, or it can be against a group, or it can be against paradigms and ideas. Next slide. And really, I am always thinking about two kinds of bias that get in the way of reducing the harm of obesity. One is the intellectual bias about obesity itself that favors our personal convictions. The thing is that everybody weighs themselves, everybody eats, and so everybody has really pretty strong opinions about obesity and nutrition and what is good nutrition, what is bad nutrition, what is healthy living, what is unhealthy pattern for living. And often those are based on personal convictions and suppositions, not necessarily empiric data. Then, because of those ideas that people hold firm to, you have bias directed at the individuals who are living with this condition. And if you take the time to talk to people who are living with obesity, especially people who are living with severe obesity, which is becoming more and more common, that bias that people experience day in and day out is staggering. It's well documented in the literature on weight bias, and it has a profound effect on the people living with obesity. Next slide. Now, when I talk about the bias that people bring to the subject of obesity, I'm really talking about viewing obesity as a result of poor choices. If you talk to an average person, whether that person is a healthcare professional or just a lay person trying to go about their life, they will tell you that obesity results from bad choices, unhealthy behaviors. And if I tell them that of these three, or ask them of these three factors, the environment that we live in, the choices that we make, and the genes that we inherit, what explains 70% of the variation in obesity? They will tell you, next slide, as this distinguished physician did, that it's really an elephant in the room. It's really personal responsibility. We are encouraging free riders who overeat and underexercise and shouldn't have the right to make innocent bystanders pay for the consequences of their behavior. Next slide. But the truth is, obesity is a highly heritable chronic disease. This is something that we have known for decades. The heritability of obesity is 70%. Heredity plays a dominant role. Of course, environmental factors are important. I don't want to trigger an argument about nature versus nurture. It's nature and nurture, not nature or nurture, of course. But what you have going on is that the genes that we inherit set the table for obesity, and the environment that we're living in serves it up. Faced with that condition, then people do indeed have choices to make regarding what to do about it. But it's not the choices that get them there, it's the environment and the genes that people inherit, the susceptibility that people inherit. Next slide, please. Something that probably all of you have heard before is that it's all about energy balance, calories in, calories out. How many calories do we consume from food? How many calories do we burn during physical activity? Does this explain obesity? Well, as a matter of fact, next slide, not exactly. There are problems with that. Yes, thermodynamics is important, but these are the thermodynamics of a complex adaptive biological system. Next slide. Other people have said, well, you know, it's not energy balance, it is carbs and insulin. And this is the carbohydrate insulin model that's been getting some press lately and stimulating a whole lot of discussion as an alternative way to looking at obesity. And this certainly has merits. However, next slide, please. As multiple publications, there's a whole line of debate in the American Journal of Clinical Nutrition just this month that says this model actually has limitations in terms of providing a simple explanation of what's going on. Next slide, please. The fact is that you have multiple factors that are driving obesity rates. Physiologically, we all have a fat mass set point that the body tends to try to protect, because when people do not store enough energy for lean times, their survival is at risk. But now we live in an environment where the food supply is altered in many, many ways, far more complex than individual macronutrients, and that affects the fat mass set point of the population. We have drugs and chemicals in the environment. There was a recent study that showed that roughly 1 in 5 individuals are receiving a prescription for a drug that will cause them to weigh more than they did before. And there are often alternatives to these. There are also endocrine disrupting chemicals in our environment that have an effect on how the endocrine system of our bodies manages our fat mass physiologically. We have a technology and physical environment that has all of us right now as we speak sitting in front of screens and having more sedentary lives that are not through choice, but actually through the default that we need to adapt to in order to live our lives and earn a living. Finally, we have various forms of stress and distress, whether it's racism or sleep deprivation or any of a number of factors that have been documented in the literature. That stress and distress serves to elevate the fat mass set point. Next slide, please. All of this interacts with complex adaptive systems. This is a systems map that was developed by a really smart group of people in the UK more than a decade ago that talks about how social psychology, personal psychology, physical activity, both the environment and the individual, physiology, food consumption, food production, all of these systems interact in complex ways. Why is this important? It's important because if you push on these systems in one particular place, for example, tell people to consume less sugar in their diet, the systems push back and people make other choices. The systems adapt, and it seems that so far the systems adapt in ways that favor an increased prevalence of obesity, a continuing trend toward more obesity. It's kind of like trying to climb out of a very sticky spider web that kind of bounces back as you push and pull on it. Next slide, please. So this bias that obesity is really much simpler than it actually is, that it is a matter of energy balance or bad food or inactivity, has an influence on research agendas and the funding of research. Next slide. These researchers who were at the University of Alabama at Birmingham say that the impact of bias actually starts with the research that we do in the scientific literature on obesity that is full of observational studies, studies with short-term endpoints for a chronic condition, surrogate endpoints that are not actual endpoints of health, but endpoints that we presume will correlate with a health outcome. There is publication bias that can be easily found in obesity and nutrition research. There is repetitive, literature of studies that builds a bias of familiarity. People hear, oh, wait, I've heard that aspartame can cause weight gain, and it was a correlation that actually showed that. And then that gets repeated and repeated and repeated. And it's a reasonable supposition, but that bias of familiarity has people accepting that there is a actual proven cause and effect relationship rather than just something that is a supposition or a speculation that needs to be confirmed. So these conjectures get advanced as recommendations that surely should reduce weight gain or produce weight loss. An example would be, the advice to eat breakfast every day. And it turns out that when you do rigorous research, that doesn't hold up too well. Next slide, please. Here is a list of some myths and presumptions, and it's worth thinking about what we know about obesity in terms of what are the facts, what are the myths, what are the presumptions. Presumptions are things that we have good reason to suspect might be true, but we don't really know that they are true or false. Myths are things that we know pretty much are false, and then facts are things where we have good empiric evidence to tell us, yes, this is what we know. Next slide, please. Intellectual investment can be quite potent in this area. There's a lot of investment in the idea that sugar is toxic. That started around 2010, 2013. There is a real conviction that sugar-sweetened beverage taxes will save lives based upon some good suppositions, but not empiric evidence that shows health outcomes resulting from sugar-sweetened beverage taxes. There are people who believe very strongly that artificial sweeteners can cause weight gain. There are people who feel very strongly that obesity treatment is futile, and that's why we have to only try to prevent it. Giving people access to obesity care is just a waste of money because they won't improve their health anyway. Most people will not, might even find their health getting worse. And then finally, just urging people to eat healthy and live an active life will prevent obesity, but reality becomes a very different thing from what people believe. Next slide, please. This was published around the early part of the teens with Dr. Lustig at the University of California at San Francisco saying, I have definitive evidence that sugar is toxic. Next slide, please. But it turns out that the exercise here was all about proving a point rather than discovering facts. That evidence that sugar is actually toxic came from a study of 9 subjects, 9 days duration. Dietary sugar was reduced to 10% in these people. There was no control group, and you have a professor of nutrition saying, you know, just putting somebody on a healthy diet can cause the metabolic changes that were observed here. And though they try to attribute this to low fructose, in fact, the design of the study does not permit that attribution to be made. Next slide, please. Likewise, you have modeling studies that say Mexico's soda tax that was implemented in 2013 would wind up saving us 19,000 lives and more than $983 million over 10 years. It was a study, yes, but it was a modeling study where the outcomes are based upon the assumptions that you make. Fast forward 8 years, next slide, please. And you find out that despite the efforts to limit sales of junk food to children in Mexico, the problem is now worse than ever. Now, people who are invested in this idea say, well, yes, but we just haven't done enough of this yet. The measures weren't strong enough. That may be true. It might also be true that those interventions alone are not going to bend the curve. They certainly have not bent the curve yet. Next slide, please. Likewise, you have a trial of a program to prevent obesity that's a really good program, really sound program. It was done as a randomized controlled trial that included an economic evaluation. However, in the conclusion of this study, they did not, in the findings, in the data that came out of the study, they did not find statistically significant effects for this study. Nonetheless, they really believe in this intervention, and they say this is cost effective because they saw a trend that was not significant, not meaningful. So my question in looking at this from an arm's length perspective, how can we say that this is cost effective if we don't know it's effective? You need to know both costs and effect in order to conclude you have cost effectiveness. Next slide, please. Because presumptions can be so potent, because beliefs can be so potent, believing can be seen and funding tends to follow beliefs. The CDC will present in public forums saying, we know exactly what works. These are the things that work. We just need to do more of them and we will reverse this problem. Next slide, please. In this way, presumptions can triumph over the complexity of obesity that we find when we take a hard scientific look at it. I get comments like this all the time. We really have a pretty good idea how to curb childhood and adult obesity for that matter. The challenge is it's just hard to do what we know needs to be done. Well, if you can't do it, is it really effective? I would ask us to think about. Next slide, please. Bias also has an influence on clinical care for obesity and the lived experience that now roughly 43% of the population has with this condition. Next slide, please. Health professionals harbor bias against patients with obesity that is well documented in the literature. Next slide, please. This is the prevalent bias that many health professionals have, which basically comes down to, and this was published in the American Journal of Medicine in 2015. It might be difficult to publish something that is so blatantly biased today because explicit bias, as I'll show you, has come down a bit. But still, this doctor felt quite free to say that I just tell patients they weigh too much because they eat too much and their health and their weight are their responsibility. End of discussion, make it right, go away and fix this. Next slide, please. Living with that kind of discrimination makes people sicker. There are pathways that are well described in the literature, from stress to obesity, which then leads to stigma, which then leads to more stress, which then leads to more obesity and the avoidance of healthcare, unfortunately. Next slide, please. Bias drives decisions that affect clinical care. I heard this at the roundtable on obesity solutions. Prevention obviously has to be the primary strategy for dealing with obesity because there's just too much obesity out there to treat. Well, there's a lot of cancer out there to treat too, but that doesn't mean that people should not receive care for it. These are health problems. These are people with health problems that are experiencing severe impact on their lives and on their prospects for healthy lives. It won't just go away because we say that there's too much of it. In fact, it will get worse, and that's what it's been doing. Next slide, please. Good obesity care requires access to the full range of obesity care tools, ranging from self-care to professional behavioral care to pharmacotherapy to surgical care and then post-surgical care. Next slide, please. But because of this bias about what obesity is, it's all too easy for health systems to discourage people from seeking care. You will find routine exclusions in health policies for obesity care, regardless of any potential health benefit. What is the first line therapy for hypertension or diabetes? It is weight management for patients who are living with overweight and obesity, but that first line approach to taking care of it is excluded from many health plans. There are lifetime procedure caps, high out-of-pocket costs, problematic reimbursement rates and procedures, all of which serve to discourage people from seeking care and say, based upon their own internalized bias, that, well, I guess this really is my fault. Maybe I need to go away and do something about it. But then just going away and doing something about it leads to the problem getting worse. And then complications from developing, which are fully paid for by these plans: fatty liver disease, hypertension, diabetes, and a whole range of more than 200 conditions that result from obesity that is untreated. Next slide, please. So for obesity, the standard of care is often no care whatsoever. Next slide, please. Self-care winds up being the only option that is available to very many people. Next slide, please. And on the way out the door, a patient, as I did, might get this kind of glib advice, which is proven to have no effect, telling the patient, you're overweight or you have obesity and you should eat healthier and be more active, and the problem will be solved. Next slide, please. Bias also influences health policy, and it influences health policy because, as we'll see on the next slide, it favors simplistic policy solutions. You may recall that in the UK, Boris Johnson had an epiphany that his obesity was responsible for him nearly dying from COVID. And he said, we're going to take this on. Well, how did they go about taking it on? Billboards saying, hey, this is my new thing. I'm going to eat healthy and the problem will be solved. Next slide. Correlations can become foundations for policy, such as the observation that thin people don't tend to drink Diet Coke, so there must be a problem with diet sodas. And next slide, you'll see that in fact people say, well, why not then limit diet drinks and artificially sweetened beverages, because we should just be cautioned and maybe that will help. Next slide, please. Therefore, in Philadelphia, for example, where they're taxing sugar-sweetened beverages, they're also taxing diet sodas, because why not? Next slide, please. The net of this is that myths and presumptions become the basis for a lot of policy decisions, ranging from the recommendations for low-fat diets in the 80s, the reliance on breastfeeding programs to prevent childhood obesity. This is not to say that breastfeeding is not highly beneficial. It is, but it's not doing a lot to prevent obesity in children. Investments to eradicate food deserts, looking back at those, didn't seem to have a big effect. And studies of restaurant menu labeling, while it's a good idea for many reasons, it does not serve to reduce the risk of obesity. Next slide, please. A similar measure is BMI measurement in schools, which became very popular around the turn of the century and spread in many places without a good empiric basis for believing that it would improve or reduce the prevalence of childhood obesity in schools, mainly because it turned out, next slide please, that kids were just being identified as overweight and told basically that they're fat. Well, the news for the folks who thought that this was a good idea is their peers were real good at telling them that they were fat. They were not unaware of that. Parents are not unaware of that. The problem is, so what do I do about it? Next slide, please. And it turns out that a randomized clinical trial, very robust, tells us that there is no benefit to screening kids in school for obesity, only the potential for harm in terms of the mental health and the future health of metabolic health of these individuals. Next slide, please. We have a lot of fear and dread campaigns such as these that are unhelpful because they simply serve to tell people, amp up the perception of a problem, the perception that people have done something wrong, without really offering a solution that will reduce risk and improve health. Next slide, please. Dietary guidance often relies on observational evidence because randomized controlled trials are very difficult. Next slide, please. So we have uncontrolled policy experiments, such as the uncontrolled policy experiment of promoting low-fat everything in the 80s and the 90s that turned out not to have the desired effect. Next slide, please. Let's think for a minute about how well health policy serves basic principles of healthcare ethics. Are we respecting autonomy? Are we making sure that we do no harm? Are we assuring ourselves that actually by implementing this policy we will do some good? And are we being fair and equitable in implementing this policy? Next slide, please. So, kind of bringing it all together, I'm going to offer you my supposition that we have two key problems with policy approaches to obesity. One would be that we have relied almost exclusively on healthy eating and active living to prevent obesity. And it may be a bit more complex than that. We have also limited treatment of obesity by and large to behavioral interventions around diet and exercise, and even limited the access to evidence-based behavioral interventions. Next slide, please. You might look at that and say, who is this guy? And isn't he just trying to make the perfect an enemy of the good? Because after all, it's absolutely true that healthy eating and active living are important coping skills for an environment that promotes obesity. I certainly pay attention to that. And I know that there are good people in this audience who are working hard to help people develop those skills and cope with that. Clearly, there's a good evidence base to tell us that the diabetes prevention program helps people avoid progressing toward type 2 diabetes. These are good interventions. Next slide, please. However, they reach a very small fraction of people living with overweight and obesity. The CDC tells us that a total of 425,000 people have been through the diabetes prevention program. It's hard to expect that these programs will actually have a big, measurable, meaningful impact on population health. So it's not that these programs are worthless, it's just that for improving population health with such a large and complex problem, they might not do the trick. Next slide, please. So we have a great need for advocacy to stop pursuing ineffective policies and find more effective policies, to provide more options, to avoid blame and shame, to eliminate gross discrimination, all of which is compounded by self-stigma. And there's a robust literature on self-stigma, which when it comes right down to it, when you're living in a world that fills you with messages that you are screwing up, you start to believe that there is something wrong with you and all of this is your fault. And that actually leads to worse health outcomes. Next slide, please. So what's the pathway for progress to reducing the harm of obesity? Next slide, please. Well, in 1977, obesity was officially not a disease. HCFA, which was the agency that preceded CMS, said, no, obesity is not a disease. And then in 2004, they said, well, it's not a disease. And then in 2013, the AMA declared, well, as a matter of fact, obesity really is a disease. Let's get real about this. Next slide, please. Since then, we've seen some significant progress. We have more than 5,000 board-certified obesity medicine physicians. The American Academy of Pediatrics now recognizes the value of bariatric surgery for kids, adolescents with severe obesity. There's a growing regard for the lived experience with obesity, and we see a impressive R&D investment in new therapies that can change the landscape for obesity care. Next slide, please. Explicit bias is going down, and that's a good thing. But as you see on this chart from research that was published in Psychological Science, for implicit bias with weight and weight alone, the implicit bias is actually growing. So we have kind of two dynamics going on where that implicit bias that kicks in before we even think about it is actually going up and making the problem worse. Next slide, please. It's important to recognize that people bring diverse perspectives to obesity, ranging from fat acceptance to, next slide, please, health at every size, where people say, you know what, I'm not going to lose weight. My life experience tells me that, but I can try to be healthier at the size that I'm living at. Next slide, please. To self-stigma, where you have somebody like James Corden really putting themselves down in the process of saying, you shouldn't be putting me down. I suck at this. I'm not doing the right things. I seem to be unable to do it. And that is almost a perfect expression of some self-stigma. Next slide, please. Then you have people whose real problems are with disordered eating, and that adds to the complication of respecting diverse perspectives on obesity. Next slide, please. You have people who go through cycles of weight loss and weight gain, and this becomes a seductive mix of myth and reality, where people think, falsely, according to the scientific literature, that losing weight is actually going to cause them to gain weight. Next slide, please. And then finally, you have a population of informed and engaged individuals who just want to improve their health. Next slide, please. So the opportunities that lie before us for better progress are to marshal our objectivity, to acknowledge evidence gaps, to use robust research to inform policy, to stay curious, to better understand obesity, to build a stronger evidence base, and then finally to care for the people who are living with obesity, improve our awareness of bias and work to eliminate it, respect for the diverse perspectives that people bring to the subject of obesity, and translate robust evidence into practice. Next slide, please. For this, advocacy is essential to demand respect for diverse lived experiences, to bring accountability for policy outcomes. It's not good enough to just implement policies that sound good. We need to know that those policies are making a difference. We need to deliver better care, better health, and better lives for people who are affected by obesity. And with that, I'm happy to take questions. Next slide, please. You can find more information here. Note that link to the PDF of my slides. I'm happy for you to download them. They're available right now. Thank you so much. Back to you, Leah.
Thank you so much, Ted. Make sure to put your questions in the chat box, so we will open up Q&A here with Ted. Let me see here. So Ted, what do you think are some of the strongest policy-based strategies that people can advocate for with regards to addressing obesity?
I think it's tremendously important to give people access to care for obesity under health plans that will actually have an effect of reducing the harm of obesity. Right now, very many people, unless they have a deluxe health plan, don't get access to those plans. For example, on Medicare, less than 1% of people who could benefit from the diabetes prevention program actually get access to it. And that's because of arcane rules about how it has to be implemented that makes it nearly impossible. Anti-obesity medicines, which are in the process of changing the prospects for obesity treatment, are 100% eliminated from coverage under Medicare. And I'm not ashamed to tell you that I went on Medicare this year. For more than 10 years, I've been taking an anti-obesity medicine that keeps me out of the range of obesity, but I can't find a Medicare plan, Advantage, supplement, or whatever, because it's not allowed, that would cover any of my expense. I'm paying 100% out of pocket, and that's wrong.
Ted, we have a question here from someone in our viewing audience. I must admit, I'm in the 70% that have believed most of the obesity issue is due to personal choice. I have a master's in public health and have been in the industry for several decades. What else can you suggest in terms of books and articles to help broaden my perspective? Great points here today.
I think what's really important is to understand the physiology of obesity and adipose tissue. Most people think of adipose tissue as some kind of inert blob of jelly. In fact, it is the largest endocrine organ in the body. And last week in the New England Journal of Medicine, there's an excellent review article on the physiology of adipose tissue, which really puts a lot of those ideas that we are the masters of our adipose tissue to rest.
I will also add to Ted's response that if you look up his website, ConscienHealth, you can see how to spell it at the bottom of the slide. Sign up for his newsletter or blog, because you get a short little brief summary in your inbox each day. And Ted does a fabulous job of talking about current issues in the field of obesity, weight bias. He covers new studies that get published. And as an obesity scientist myself, I can vouch for his scientific approach, really paying attention to the evidence. So if you're interested in challenging yourself to think differently about obesity, please go to ConscienHealth and consider signing up for regular updates of Ted's blog. Okay, we have another comment here. Thank you. I have found it striking that people talk about obesity and COVID a lot, but being a Black man carries more risk than obesity. This seems to indicate to me that bias and allostatic load from stress contributes similarly to deaths in people with obesity as it does to Black men. Do you want to comment on that at all, Ted? I thought it was an important point to bring up.
Well, it absolutely is an important point to bring up. And it's worth noting that none of these things operate independently. access to care and the conditions that promote obesity disproportionately affect people of African American descent. And physiologically, obesity has a profound effect on risk of serious illness and death from COVID, but likewise social determinants of health that follow disadvantaged communities also has an effect on the risk that COVID pays. So we really need to be paying attention to this, and we need to be paying attention to providing options for obesity care that are actually fitted to the need for people who come from these communities. Historically, there's a good literature out there that says we have done a terrible job on this.
Thank you for that response. Can you say more about healthy at every size? Is it real or an excuse to not search for answers?
Well, the belief that this is an important approach is, I can testify to you, very, very real. You will find passionate communities of people who advocate for the idea of health at every size. And just speaking of my own beliefs, perceptions, and biases, I find about 80 to 90% of what the advocates for health at every size have to say is extremely valid. The part that I have trouble with is the assertion, however subtly it's made, that obesity is not really a thing. The argument that you often hear is obesity is defined by BMI. Note carefully, it is not. But obesity is defined by BMI. BMI is flawed, so obesity is BS. Don't pay any attention to that. I have a tough time going along with that because it's not really grounded in evidence. It's grounded more in a belief, a conviction. Those beliefs are real, but they're not based in evidence. And so it's important to understand what obesity is. Obesity is real. And we don't have treatments that are acceptable to everybody that will actually cure it. So there are many diverse perspectives that people bring that we absolutely have to respect.
That is such a good point, Ted. Thank you. Here's the next comment. This felt very fatalistic. Have we given up on prevention and being able to get back to the obesity prevalence of the 1970s? If not, how can we reduce the prevalence? Seeing surgery as a solution for adolescent population level obesity is very unfortunate.
Well, so that is a valid point, and it is discouraging. It's hard for me to look at 4 decades of rising prevalence and consider that against many, many efforts to change it and not feel a bit discouraged. But I do not feel fatalistic about it. And if you want to really understand what my thinking is, take a look at the post that I did yesterday on prevention for Obesity Care Week. I think prevention is critically important. In fact, it's so important that going based upon presumptions that this ought to work, and so we'll just close our eyes, do it, and say it's going to work if we work hard enough at it, is not good enough. We need to be more objective about what we know works, what doesn't work, and what might work but we haven't proven it. We need to be curious to find ways to have an impact on population health. So far, I think the empiric evidence would tell us that we haven't figured out how to have an impact on the prevalence of obesity.
We have time for one more question. Thank you for the talk. So once you improve access to care, what would healthcare professionals recommend with all the current biases? What are your thoughts on the intuitive nutrition approach, if any? So technically that's 2 questions. You can choose to answer one or both.
So the approach called intuitive eating has benefits, especially for people with disordered eating, there's not a good evidence base that says intuitive eating by itself is a highly effective treatment for obesity itself. But that's not to say that that it has no value. It has value for disordered eating and sound approaches to nutrition. And you can talk to folks who are well schooled on that to get into that literature, but you won't find a lot of solid literature that says intuitive eating will help you lose weight. And then the second part of the question I did want to answer and my brain went blank.
What would healthcare professionals recommend with all the current biases? Once you improve access to healthcare, what would healthcare professionals recommend with all the current biases?
Well, I think primary care professionals need to get better at actually providing evidence-based care for obesity, so that they could recommend that spectrum of approaches to treatment. But for now, what's happening is more and more people are developing expertise, are getting board certified in obesity, and learning how to individualize therapy to the needs of the individual, because truly in treating obesity, one size does not fit all. There's a great heterogeneity in response to individual interventions, and a really smart obesity medicine physician will tell you, I just have to work with the individual to find what's going to work for them.
Thank you. We need to transition to the next segment of our webinar today. I will say, for anyone who didn't get their questions answered, or if you want more information, we will have contact information at the end of the webinar. Please feel free to reach out to us. We can follow up with you by email with additional information and resources, including related to that last question about healthcare professionals. We as a team at Live Smart Texas and through the UT Health School of Public Health have lots of resources available to healthcare providers. So please feel free to reach out to us if you'd like to follow up for more information. All right, now we are going to turn it over to Dr. Emily Durander, who's going to introduce our next segment.
Thank you so much. So thank you so much, Ted, for that insightful talk. And next up, we would like to hear from our Live Smart Texas Steering Committee members on obesity-related updates that are happening in their regional areas that they represent. So first up, we have the presentation from Mr. Michael Lopez regarding Texas AgriLife Extension Service.
I'm not hearing any sound.
We cannot hear well, Emily.
So we had tested this earlier and did have to make a minor tweak. So just give us 1 second and we'll get the sound working again. Okay, so we had pre-recorded these just so everything went smoothly, but that's all right. Mike is with us. So Mike, would you be able to just present your slides for us?
Yes, no problem. Would you happen to have the slide deck there, or do you want me to bring it up?
We do have it. We can bring it up. Thank you so much.
Of course.
If you would like, I have the recorded version on my computer and I can play the audio with my microphone open. Would you like to try that?
I'm good either way, whatever y'all feel is best.
Let's see if you can hear this. Howdy.
Howdy, my name is Mike Lopez, and I serve as the Texas A&M AgriLife Extension Service Organizational Representative for LiveSmart Texas.
Yes.
I've been honored to serve LiveSmart Texas in this capacity since 2016. With over 10 years of service to AgriLife Extension, my role is to support county extension agents for family and community health in their efforts related to active living. Currently, I provide leadership for 3 online team-based physical activity programs and oversee the statewide implementation and evaluation efforts. For today's presentation, as part of the World Obesity Day Summit, I would like to share updates on our extension efforts related to active living through one of our web-based physical activity promotion programs, Walk Across Texas. To begin, I would like to share more about AgriLife Extension. Texas A&M AgriLife Extension is one of the land-grant institutions in Texas. Our mission statement provides the purpose and mandate for the vast network of professional educators that serve each of the 254 Texas counties. There are different disciplines and program areas represented to address the needs of Texas, but the overall goal is to change human behavior. Selected family and community health programs specifically address physical activity in support of chronic disease prevention efforts. The Walk Across Texas program highlights, supports, and celebrates the success of the AgriLife Extension program development model in practice. The idea of a physical activity program began in response to the 1996 Surgeon General's report on physical activity and health. In the report, there was an identified need of increasing physical activity to improve people's health. In response, a team that included specialists, agents, and administration coordinated the development of the Walk Across Texas program alongside other school and community leaders. The first event kicked off on September 15, 1996 at the Marshall Mall in Harrison County. Today, we still recognize best practices that were developed when hosting the very first event. After a successful pilot, the program was expanded from 1 county to 20 East Texas counties. By 1999, the program was expanded to all regions across the state. To further support program outreach, a website was developed and pilot tested. The website was released in 2002 for use in all counties. Other accomplishments of the Walk Across Texas program over the past 25 years include the development of the youth program that now includes over 250 lesson plans, newsletters, and a recently updated implementation guide. The program was also recognized by the Department of State Health Services as a best practice physical activity program. Recently, the Family and Community Health Unit has dedicated resources to invest in technology-based strategies to increase program outreach. In September 2018, the Howdy Health platform was released, which now allows participants to select from a menu of family and community health program offerings. With the transition, we were able to differentiate the adult from the youth Walk Across Texas program. Each unique program design uses a theoretical approach to target key health-related behaviors. And since the launch, we've reached over 125,000 participants, including the largest participation ever with the Walk Across Texas program in 2019. The objective of the Howdy Health platform is to simplify and modernize existing family and community health programs to create a sustainable platform for new online program development. The website for program implementation requires an account to manage or participate in the programs offered. The ability to have an account offers individual and multiple program monitoring, tracking, and a historical section of previous participation. Internally, this supports our ability to evaluate the effectiveness of the programs offered and measure impact and share our story with participants and stakeholders alike. Website features help enhance the user experience, especially the help desk, which is a one-stop shop for program-related questions and technical support. Listed on the slide are the current physical activity program offerings, which includes 5 unique programs for various audiences. On the far left of the screen, we have our adult team-based physical activity programs, which include the Walk Across Texas Adult and Walk Through Texas History program. In the middle, we have our youth team-based physical activity program, which is the Walk Across Texas Youth program. And finally, we have 2 other adult programs that focus on individuals, the 10,000 Change Challenge and Live 100. Each of these programs have their unique program duration, design, and theoretical framework to support physical activity behavior change and help participants adopt a healthier lifestyle. All programs are available for free, and if you would like more information about any, please feel free to reach out to me. Since 1996, over 650,000 participants have started their virtual journeys across Texas, which has led to an economic benefit of over $2.25 billion. The economic benefit of the Walk Across Texas Adult program is a measure that uses Walk Across Texas program evaluation results, disease risk rates, healthcare costs, and productivity parameters. Economic benefits are calculated for program participants who moved from self-reported inactive, pre-Walk Across Texas, to active, post-Walk Across Texas. The final number of participants benefiting is based on a follow-up survey that determined the percentage of those who maintained physical activity levels. By engaging in regular physical activity, this reduces a person's risk of disease each year of their remaining life. The dollar value of the economic benefit of Walk Across Texas is calculated in terms of the projected lifetime healthcare cost savings and worker productivity gains. In terms of effectiveness, a recent study confirmed an increase of self-reported mileage during the program, along with an increase in the number of days active. We are also about to submit a manuscript that confirms the sustained effectiveness of the program up to 150 days after the program is completed. We are about to release a report from our 2021 participation, but preliminary results highlight an increase in physical activity, a decrease in those that report being physically inactive, and 95% of program participants felt that they and their family benefit from participation in the program in 2021. The WA Adult program relies on constructs from multiple public health theories and models. The utilization of different theory constructs allows the program development team to consider all of the factors that influence a behavior, specifically physical activity in this context. The main theoretical framework used to guide the development of the program design was the social cognitive theory. Social cognitive theory is one of the most widely used and published theories in public health practice. This theory provides an evidence-based approach and framework to address physical inactivity in Texas. Each concept of social cognitive theory can be applied to a central component of the Walk Across Texas Adult program goal and design, as highlighted here on this slide. Here, we can see the theory in practice with participant testimonials that highlight each key concept or construct. In my opinion, the team-based approach, which reinforces social support and role modeling, is what makes the Walk Across Texas program so unique and enjoyable for participants. To end, I would like to thank the local county extension agents across Texas for their continued support of the Walk Across Texas program statewide. Further, I thank the other extension faculty involved in the program development, implementation, and evaluation process. Finally, I would like to thank the numerous participants who, for over 25 years, have been supported and surrounded by friends, family, coworkers, and hundreds of thousands of others on the virtual journey across Texas. Please remember, the journey on the road to a healthier life begins with a single step. Thank you, and I would be happy to answer any questions.
All right. So thank you so much, Mike, for that terrific talk and update about Walk Across Texas. So we do have time for 1 or 2 questions. And so while we kind of wait for those to come in, I will just quickly ask you, this has been such a long running program, and I would love to know if you have any insights on what it takes to keep the momentum going for something to happen year after year like this, if you have any insights to share.
Yeah, definitely. And we're certainly blessed with, the sustained support of the program, not only internally within Extension, but also externally with our amazing partners, the various organizations, schools, et cetera, that continue to support the program, that continue to come back and enjoy, reaching the program goal and engaging in it, especially with their fellow team members and that social support aspect. So that's really a big part of it, is that communities really, it resonates with a lot of participants across the state with that goal of, that virtual journey of walking across Texas and getting together and almost recognize, the certain times of year when their local communities sponsor events as part of the program to help support their journey. So we're really appreciative of our county extension agents all across the state that continue to support it, and certainly internally to help maintain some of the resources to help with our technical support, as well as some of our programmatic support to help answer questions.
I see. Yeah, it's quite admirable. And we did have one question from the audience. Someone's curious to know, what are the dates for Walk Across Texas 2022?
So technically, there is no official start date of the program. It is open access, so any team or a collection of teams, which is what we call leagues, can start the program at any time. But there are some locally sponsored events or challenges that happen depending on where you're located. So if you're within the state, I highly recommend reaching out to your local county extension agent to see when your local, if there is a locally sponsored program happening locally. We do offer some statewide coordinated programs as well. And so we could certainly connect you with that if you'd like to reach out to me. If you're coming from outside the state, and just would like to get a team together and see if you could virtually walk across the state of Texas or use the tracking and monitoring to walk across some other location, you are able to do that as well. We do have an out-of-state registration option as well, just in case, since we do have a national and international audience today. So you could also take part of that. So no official start date. You could start the program at any time. There's no restrictions on that.
Awesome. Well, thank you so much, Mike, for that update from Texas AgriLife Extension Service. And next, we will hear from Dr. Naima Musted Musa on updates from Health Service Region 1, which is Lubbock and the surrounding area.
Emily, are we doing, I thought we were, sorry, I had a different order on my slides. We're going to Region 1. Okay. Hang on one moment. Okay, here comes the audio.
Hello, my name is Naima Musted Musa, and I'm Home Distinguished Professor in Nutritional Sciences in the College of Human Sciences and Director of the Obesity Research Institute at Texas Tech University. I am here today to present some of the work that is ongoing in Region 1 in West Texas. And I'm doing so on behalf of LST, Live Smart Texas, in which I serve as a steering committee member. So the first program is a health program. It's a healthy eating and active lifestyle among teens in rural high schools in West Texas. So this is a adolescent obesity prevention program where the goal is to improve healthy eating, increase physical activity, but also the emphasis is on stress management and on providing practical cooking skills. So this work is ongoing currently into rural schools with 11th and 12th graders, and the recruitment is also ongoing to extend this to other rural schools. This program is led by Dr. Roki Park, who is faculty in the College of Human Sciences, and the information is here. The second program is from the Community Nutrition and Health Interventions Lab, led by Dr. Wilna Odubash-Peron. She is professor in nutritional sciences at Texas Tech. And the first set of studies dealt with the impact that COVID-19 had on seniors. She and her students surveyed 250 seniors in Lubbock County and assessed the impact of the pandemic on food security, access, diet, diversity, and lifestyle behaviors. She has already collected the data with her students and hopes to share the findings soon. The other study was conducted with Texas Tech students to assess how in unemployment or reduced work hours affected food security, employment, or dietary intakes in these students. And preliminary findings showed that reduced work hours due to the pandemic was associated with fast food eating and unhealthy eating in general. The Community Nutrition and Health Interventions Lab also has developed a multi-component e-health intervention working with toddlers, and they have recruited about 70, and they developed a healthy online parental education program or HOPE, and the goal is to increase fruit and vegetable consumption and also active playtime at home. Dr. Winner's information is indicated at the bottom of this slide. We have another program that uses human-animal interactions to improve children's health. In this case, it's an equine-assisted positively fit program that is a collaboration between the psychological sciences and animal and food sciences at Texas Tech University, and the contact information is below. And they are recruiting children 9 to 13-year-old and their families, and the focus will be on horse-assisted healthy lifestyle lessons to hopefully improve the health of these children. Another program is OLE, or Outdoor Learning Environment. So this is an initiative of the Texas Department of State Health Services, the SHS. The website can provide more information. It's a partnership with other universities as well and organizations. And this is using the built environment as a design intervention to promote health and wellness. And the goal overall is increasing green space. This is led by the Texas Coalition for Natural Learning, and this is primarily led by the College of Agricultural Sciences and Natural Resources and the College of Human Sciences faculty. These are some examples of interventions, as you can see here, increased green space in this outdoor environment. The first one shows the Child Development Research Center. The second one is a master plan approved for pre-intervention behavior mapping at the Alpha Academy in Pasadena, Texas. And the third one is an example of the outdoor learning environment that was proposed for the YWCA in Lubbock through a design workshop that was done recently. The coalition has developed several resources as shown here. This is the website for more information, and this is the contact information for Dr. Christy Gaines, who is professor in the Department of Design in the College of Human Sciences. Also, the Texas Tech Psychology Clinic provides the energy program, which is an outpatient behavioral and health services for weight management. The goal again is to reduce or prevent childhood obesity through various interventions with children and adolescents ages 2 to 17. This includes family meal planning advice and nutrition education, as well as clinical visits to monitor progress. And this is the contact information if anyone needs more information about the program. We have the Nutrition and Metabolic Health Initiative in Nutritional Sciences at Texas Tech University. And NMHI provides clinical services that include weight management, nutrition counseling, metabolic testing, and body composition. There are several ongoing research projects where students and faculty are engaged. And this includes, for example, a 12-week ongoing program for weight loss for women age 18 and over. Another study is to look at the effect of potatoes and various cooking methods on blood pressure in patients with type 2 diabetes. Last but not least, CNMHI holds community events, including one that is held today during the World Obesity Day. The Garrison Institute on Aging is another community resource. We focus in part on community outreach and education. They have several programs, for example, Healthy Lab to promote healthy eating, active living, and education. It's a collaboration with the Mayor's Fitness Council, and they also work with Farmers Market to promote community gardens and provide lecture series on healthy aging. They also provide workshops on self-management of diabetes and chronic diseases, as well as care partner workshop through monthly meetings with caregivers, and also provide volunteer opportunities for retired senior and volunteer program or RSVP. Dr. Volkan Yuga-Bauer is the director of the Garrison Institute of Aging. His contact information is here, as well as Dr. Gabriela Ashworth and Adipose investigators with GIA, and the link to their website is here as well. The Obesity Research Institute provides several scientific and community programs. We have one upcoming for the International Women's Day on March 8th. We're holding a webinar on women's health. We have speakers, Dr. Santoro, Dr. Pai, and Dr. Godahan from the University of Colorado, Texas Tech Health Sciences Center at Texas Tech University, respectively. And they're going to cover topics that range from breast cancer, fertility, and metabolic syndrome. We also have the plans for on Obesity Research Institute annual meeting that we focus this year on mental health, and it's planned for May 11th. Please contact me if you need more information, or contact me, Johnson, ORI Program Manager, if you are interested. We have a funded program by USDA to train undergraduates in research and community engagement. It's Nutrition Bench to Community Engaged Scholars of Texas, or Nutrition Desk. This is a partnership with several universities, including University of Tennessee Extension, Texas A&M AgriLife Extension, where the students have opportunities to do internships within the community, Texas Tech Health Science Center, and also with Hamad bin Khalifa University, where our collaborators and mentors will provide expertise in machine learning, for example. We have several units within Texas Tech in basic and community research, and this is a partnership with the STEM Corps as well. Last but not least, the Mayor's Fitness Council in Lubbock is holding a marathon on April 22nd. The registration is open, and they also provide funding for community organizations to address obesity, and have several local nutrition resources that are also relevant to obesity and health in general. Thank you very much for attending this presentation on behalf of LST, and for your engagement in World Obesity Day. And this is my contact information if you need additional information. Thank you very much.
All right. Thank you so much, Naima, for the updates from Region 1. And we do have time for one quick question from our audience, if anyone has one. Just seeing here.
If not, the slides have contact information for each of the programs, so feel free to reach out either to me or to Emily or to anyone that is listed on the contact information. Thank you.
Okay, yeah, it seems like there are no questions right now. So thanks again for the update, Naima, and for being here today. And so next we have an update from El Paso. So the regions 9, 10 for Live Smart Texas encompass the El Paso area. And so we have Pema Garcia today, who will be giving the update from that region.
to Region 910. I'm Pema Garcia, the Regional LST Representative, gladly sharing partner updates. Clinic treatment and management of obesity. The UT Health Center for Community Health Impact is partnering with primary care clinics from the region, such as San Vicente Family Health Center and La Clínica de Familia, to develop tools like Small Changes, which is a mobile app, to support healthcare providers and patients in the treatment and management of obesity. Healthy foods and resilient food systems. The Food Access Impact Pyramid details strategies that communities can work towards addressing the limitation of foods for our residents. Local programs address each level of the pyramid, from expanding healthy food retail access to nutrition education, along with some dietary counseling. Key partners from across the region are working together to improve access to healthy food and strengthen our regional food system through programs like Fresh Start, which addresses the root causes of hunger through food pantries, including case management to assist individuals with goals like learning English, or job search, as well as nutrition and physical activity. El Paso County's Healthy Food Financing Initiative drives economic development around healthy food retail and the infrastructure to support it. The Veggie Prescription Program by La Semilla, in partnership with La Clínica de Familia, with funding from the USDA. The Colonias Program, helping families make better meal choices and training community health workers to lead cooking demonstration classes and family physical activity groups in hard-to-reach areas. In-store programming, the partnership of the In-Store Coalition, where organizations coordinate to deliver nutritional education, SNAP enrollment with outreach, and the healthy screenings directly with consumers at local grocery stores. The City of El Paso has been focusing on yearly assessments of the infrastructure and policies in place that drive healthy lifestyle choices. Assessment results assist with policy implementation and recommendations. Be Well El Paso helps locals learn about simple everyday techniques, easy to implement, that help people develop and maintain a healthy lifestyle. The El Paso Healthy Schools Coalition includes 9 school districts throughout El Paso County and numerous organizations and government partners, all working collectively to ensure all children have healthy environments in school. Within this coalition, the El Paso Safe Routes to School Task Force has been formed to develop a strategic plan to promote active transportation to school. Texas Tech El Paso HEAT Team is a medical student, faculty, and promotores organization that helps bring disease prevention education to the community, and in particular, the aging community near the medical school campus. Future physicians engage with residents by organizing fairs, physical activities such as walks, and educational sessions on nutrition, the coronavirus, and vaccines. This was a snapshot of what organizations are doing around Region 910 to help address obesity and related disease prevention in 2021 through 2022.
Thank you so much, Pema. And we do have time for a few questions about what's going on in the El Paso region. And so we'll just wait for those to roll in. And in the meantime, Pema, is there anything that you wanted to highlight or add on from your talk?
Well, only that thankfully we have many partners in our region that are really working hard on healthy eating and active living programming. So it is not hard to pick up the phone or actually look online to find a program in your neighborhood. So, and it's really nice to see that there's a lot of programming all over Texas. So thanks to our partners in the community, there is a lot happening in West Texas for sure.
Yeah, it's impressive. And it seems that we don't have any questions so far. But again, is there anything else that you would like to add or any other updates since you recorded the talk?
Not at the moment, but if anyone does have questions, they're free to reach out to me or to reach out to Dr. Leah Wiggum, and we're both in the region. So thank you very much for the opportunity.
Okay, thank you, Pema, for the update. All right, and so next we have an update from Dr. Belinda Renninger. She's in Brownsville, and that's Region 11 for Live Smart Texas. And so we'll just get that started.
Hello, everyone. My name is Belinda Renninger, and I'm proud to be the Live Smart Texas representative for Region 11. I'm also the UT Health School of Public Health Regional Dean in Brownsville. Pleased to talk about some of the activities happening in 11. The work that I'm going to be featuring is partially and mostly driven by the collaborative action board of this region. It's over 200 organizations that came together since 2003 to address the high rates of obesity and diabetes in the region. Then this region is plagued by persistent poverty. Our collaborative action board is driven by the belief that our region can be the healthiest place to live in the state, and that our region has numerous assets that can be leveraged to build this vibrant, healthy community. One of the programs that has come from the Collaborative Action Board support is the Tu Salud Si Cuenta program. This program has grown from 1 city to now 12 cities working together in this collaborative to bring policy, environment, system improvements to best promote physical activity and healthy food choice across Cameron and Hidalgo County. Part of this work includes 200 free exercise classes each week. And as COVID has come through the region, the classes can move online and be offered virtually, or can be back out into the many different sites and locations of the program. Thousands of low-income uninsured residents are reached through this programming. And we also couple social media and mass media to promote behavior change through appropriate health behaviors. These partners, these organizations that came together around that particular program then had a bigger vision, thinking about how can we create a trail network now called the Cara Cara Trails. This trail network is an initiative to create regional tourism on a world scale, promote social equality, and fuel a strong regional economy. The trail system, once it's complete, will be 428 miles of on-road, off-road, and waterways across Cameron County. The Come Dream, Come Build, CDCB, coordinates this initiative. Other partners include the Valley Baptist Legacy Foundation, the UT Health School of Public Health, the City of Harlingen, Town of Laguna Vista, City of Los Fresnos, City of Rio Hondo, City of Los Indios, City of Port Isabel, City of San Benito, City of South Padre Island, Rails to Trails Conservancy, and more. There is a lot happening in this last year with the Cara Cara Trails. Trail counters are being installed as new trails are completed in order to document the impact of the trails on transportation. The City of Combs has a new hike and bike trail scheduled for completion in this first quarter of 2022. Their residents will access the local park and the soccer fields via this hike and bike trail, and eventually will connect to the City of Primera Trail. The Grande feasibility study is now underway with public input to look at this 20+ miles segment of trail that will go from the Palo Alto Battlefield National Historic Park to Port Isabel. This is one of 6 catalyst projects of the Cara Cara Trail and will create unique access to coastal lands and wildlife once completed. Port Isabel's Arturo Galvan Coastal Park is almost complete. This is a tranquil space on the Laguna Madre Bay, and it's perfect for fishing and bird watching. The park is designed with sustainability in mind and features a large pavilion, restrooms, playground, kayak launching areas, bird watching blinds, park benches, and a walking trail. And then in November 2021 launched Storytime on the Trail, which is a partnership by the Brownsville Southmost Nature Trail. And it's where the Brownsville Public Library and the Parks and Recreation Department of the City of Brownsville created a story walk project that combines literacy with movement in nature. Speaking of nature, the Collaborative Action Board priority for 2022 is increasing opportunities to access nature-based programming as a strategy to address mental health and well-being through physical activity. And this came through discussions around the CAB about how COVID and being away from one another and being indoors has created a bigger and more obvious need for being out in nature and increasing our physical activity. Towards that end, and because of the partnerships, we now have a program funded by the Rails to Trails Conservancy called the Tu Salud 50 on the Cara Cara Trails. It involves yoga, stargazing, bird and nature walks, and kayak excursions at the trailheads of some of these wonderful locations. And you can see that we promote these events in all sorts of media, and the events have been going great already. Another exciting time was when we saw the West Rail Trail groundbreaking, and after 13 years of hard work by grassroots residents and officials, we will not have a toll road or a highway or even a car running through this particular corridor in West Brownsville. This area is one of the poorest communities in the Brownsville area. And so instead, we will have this 8-mile trail that will transform the corridor where Union Pacific trains used to travel. The trail is now being laid, and there is great excitement in the community. One of our terrific partners and organizations I want to highlight in this effort today is the Brownsville Wellness Coalition. This organization is a nonprofit organization that leads the Brownsville Farmers Market. And in addition to that, as if that wasn't enough, they also run community gardens. They now have 5, and they have an urban farm. The urban farm sells at the farmers market as well as to local restaurants. The coalition also provides the Happy Kitchen, La Cocina Alegre. This is a program by the Sustainable Food Center in Austin, Texas, and is now being implemented in South Texas. Cooking and nutrition classes that teach individuals how to prepare meals that are delicious, nutritious, seasonal, and affordable. The Brownsville Wellness Coalition uses this 6 weeks curriculum to provide free training to participants in the communities facing health disparities. Finally, I want to mention our collaborative implementation of the Diabetes Prevention Program. This is a collaboration across local nonprofit organizations, city clinics, and county area clinics in Cameron and Hidalgo County. The program has been awarded preliminary recognition from the Centers for Disease Control Prevention Recognition Program. Last year, there were 13 courses implemented in Cameron and Hidalgo counties. We screened 204 participants and 197 were enrolled. 74% are considered active participants. We show in the evaluation that over 70% of the participants at multiple time points have reported increasing healthy food choice, and over 55% of participants at multiple time points have increased physical activity. I'm so proud to represent Region 11 with this flash presentation. Thanks for listening.
Thank you so much, Belinda, for the update. There's a lot going on down in Brownsville. It's so encouraging to see that. And I would love to just open it up again for questions. And in the meantime, I was wondering if you, it looks like, yes, okay, I do see you on. So I just wanted to see if you could speak a little bit more to the program that you all are doing with very different kinds of physical activity, like things like stargazing and kayaking. I know you had talked about how there was a lot of excitement around those less conventional forms of physical activity. Could you speak to that a little more?
Sure, absolutely. You know, our collaborative action board really noticed that the idea of being in nature and the facts that there's mental health benefits to that and being out and active would be, you know, a new way to engage populations in our area. So the programming options are all because of leveraged relationships, partnerships with local organizations that can provide the stargazing and the yoga and the kayaking. So these are these wonderful resources locally, and now we can coordinate and bring more attention to that work through this particular programming, building on kind of the momentum of the Tu Salud Si Cuenta program and the exercise, you know, being kind of known for getting exercise out there, then we can build on that momentum. So it is, you know, people are attending, they love it, they're doing different things, and they're seeing our trails, they're seeing the opportunities in nature.
Okay, and you speak a lot about the that collaborative group that you work with. Can you speak just a little bit more about the history of how that was formed and how it came about?
Sure, sure. And it doesn't look like my webcam is connecting, so I don't know what I'm doing wrong on that. But anyway, I am, yes, very proud to talk about the Collaborative Action Board. When we were fortunate to have a location of the School of Public Health in this region, it became very clear and very important that we needed to connect and hear from and partner with and program with and learn from and evaluate with organizations that have been here for years and doing great things. And so that was the impetus of the CAB, and it's just, you know, grown so that we have a large partnership and a network of programs and people who work together to get things done. You know, our area is not a high resource area, and so we're very good at having a vision and having commitment to getting things done and working together to do it. We've got have about 30 people watching our this webinar today in person, as well as others across the area. So I'm super excited to be with these folks today.
That's wonderful. Yeah, I can sense the energy, and it comes through with all that you're doing. So we did have one question roll in, and so I'm not sure if this is something that you can speak to, but how do you recruit participants for the Healthy Kitchen program? How do you get them to commit to the multiple classes?
Yes, so the Brownsville Wellness Coalition has done a really terrific job in thinking about every piece of their work, leveraging it to motivate individuals and offer programming opportunities. So, for example, at the farmers market, they can let people know about the Healthy Kitchen program through programming with the Diabetes Prevention program, or our robust Salud y Vida, which is a chronic care management program for diabetes. We can refer people to this program. So it's really a combination of outreach as well as referrals that allow individuals to take advantage of the Cocina Alegre program.
Awesome. Well, it looks like there aren't any other questions. Thank you again, Belinda, for the update and all the great work you all are doing. It's very exciting. And we have one last presentation for today. It is from Action for Healthy Kids, and we have Michelle Smith as part of our Live Smart Texas Coalition, who will be giving the update.
Good morning. I'm Michelle Smith. I'm the Texas State Coordinator for Action for Healthy Kids, and I'm excited to be here today to represent Action for Healthy Kids and to represent Live Smart Texas and their work in preventing obesity across our state. Today, I'd like to talk about our work with School Health Advisory Councils and the formation of the School Health Advisory Council Network. Just a bit about my organization first. Action for Healthy Kids is a national organization that started out 20 years ago, working with state teams to help schools be healthier learning environments. These teams were formed when Dr. David Satcher, then the Surgeon General, declared we had an obesity epidemic, And he gathered together experts from across different child-related entities, and they determined one of the key places to focus on prevention of obesity was through schools. Changing adult behaviors would be good, but raising children to eat healthy and be physically active would keep them from growing up with unhealthy habits and the potential for obesity. So Action for Healthy Kids was formed, and each state brought teams together to work on improving physical activity and nutrition in the school environment. This work was primarily done through policies and programs. We continue to focus on nutrition and physical activity, but there are many issues that impact our children's health and their ability to be successful and grow up healthy. So over time, we've expanded our focus to incorporate the whole child model. As Texas Action for Healthy Kids, one of the important things that we do is provide information and resources to school districts and parents. Through our monthly newsletter and national tip sheets, and by hosting webinars around wellness topics, we reach out across 4,000 members across Texas. A lot of our work has been directed at supporting school health advisory councils. During the 2020 school year, as the pandemic was advancing, we provided learning sessions on school reopenings, community engagement, school nutrition, vaping, physical education, and recess. So far this year, we have hosted a diversity, equity, and inclusion webinar, one on the implementation of the new physical education and health. And in January, we hosted a town hall session where SHAC's members and others could come together and talk about topics that they were concerned about. Earlier this month, we hosted our annual Action for Healthy Kids Summit virtually and shared information on the new laws that are impacting SHACs and other topics. Excuse me. Before the pandemic and starting again this past fall, students are spending much of their day at school, and the quantity and quality of foods, beverages, and physical activity opportunities that they have at school are important not only to keep them healthy, but for the development of lifelong healthy habits. A lot has changed over the past 2 years, and making sure we have nutritious food and time for kids to be physically active could be even more important now than it was before the pandemic. It's a fact that behaviors learned during childhood are often carried into adulthood, and the primary school age is critical in the formation of self-preserving attitudes about health. This makes schools a primary setting for tackling childhood obesity by targeting nutrition and physical activity. The statistics you see here are just a few of the reasons why schools are so important to child health and their academic success. Which leads me to one of the most important ways for districts to get needed input and even expert advice around school health topics. School health advisory councils, or SHACs, in Texas have a history that dates back to the late 1990s. They are mandated by state law to review and make recommendations to school boards on all issues relating to child health. Section 28.004 of the Education Code outlines all of the responsibilities and the regulations that govern SHACs. A state SHAC was also put in place to help guide districts and the Department of State Health Services in their implementation of coordinated school health. It's known as the T-SHAC. The T-SHAC has developed a SHAC guide, provided resources on best practices, and supported SHAC work over the past 20 years. This state-level support is critical for our districts to be able to provide quality programs around child health. In 2020, when it became clear the pandemic was not going away, we established a work group to focus on how we could better support SHACs and how they could play a role in supporting districts around child health. Several of our steering committee partners, as well as 5 school districts, meet regularly to talk about what districts are facing and how SHACs could help. This led to the realization that we need a way to connect with SHACs across the state and provide as much information and as many resources as possible. So we started working to develop a SHAC network last summer. We're encouraging parents, school staff, and community members to join SHAC network. Even if you're not serving on a SHAC, you can provide community or parental input and help direct where SHACs focus their energy. We have almost 200 individuals so far, and we hope to grow that number substantially. We also determined there was a need for basic information that could be shared out about SHACs, their purpose, and how important their work is. We've just completed the resource you see here, and we will be making them available on our new Shack networking microsite. The work group felt that we needed one to explain to parents why Shacks are so important, one that would share a bit of information for new Shack members on what their role is on Shack, and one that Shack members could share with their legislators so they have a better understanding of Shacks. This past session, it became very apparent that legislators did not understand the true scope of responsibilities for Shacks and how important they were. We hope to do more educating in the coming months before the next session. And finally, we realized we needed a place where districts could find the information they needed about Shacks, the laws, as well as resources that can help districts develop good policy and support implementation. This is a snapshot of the Shack network microsite, which is still under development. We hope to have it completed this month or in early March. This will be a work in progress as far as information that's put on the microsite, and we will keep adding as we go. I would like to mention that United Healthcare has provided support for our 3 Shack one-pagers, as well as our Shack microsite, and we are very appreciative of their support. One last thing before we open up for questions. We're excited to share an upcoming webinar on advocating for school health. During our recent summit, there was a lot of interest in advocating for better policies around Shacks, and to do that, we need boots on the ground that can introduce themselves to their state legislators, particularly during this time when they are not passing laws, and make sure they understand exactly what Shacks do and how important they are. Joel Romo and James Gray are 2 of our most engaged and talented government affairs staff, and they will be sharing tips and explaining how easy it is to get involved and truly make a difference. While COVID-19 pandemic has been center stage for almost 2 years, the consequences of the pandemic on our schools and our children will be played out over the next 10 to 20 years. We must make sure our schools have the knowledge and support they need to keep our kids healthy and safe, not just from COVID, but from all the other issues they face. Let's find a way to work together and make sure our kids' health is priority 1. Please join the Texas Shack Network so we can build advocates to support child health through our schools. I'd like to thank you for being here this morning. Please reach out via email, and I'm happy to schedule a time to talk further if you have questions. Thanks.
Thank you, Michelle. That update was so informative, and especially the centering on Shacks and the impact that they can have. So as we wait for some questions to roll in, one that I had actually was if you could speak a little bit more about just Shack recruitment, like how do you get people to, can you speak to that in more detail?
That's a good question. And it's very challenging if you're in a small district because everyone is spread so thin. So, one of the ways is to get principals to identify parents who are engaged, get with soccer moms who are obviously, encouraged that their kids to be physically active, work with your ag extension agents. Most schools have a school health specialist or someone who works directly with families. You can recruit through them. So those are just, a few of the ideas. We've recruited, have each principal nominate someone from their campus, and then go to your community, get someone from your medical community, get someone from your public health, as I mentioned, ag extension. So you need those community members to participate as well. And sometimes people don't think about how many community members really touch a child's health, and they should be part of the work around, what's important and how we resolve some of these issues.
And so the actual, the other thing I was wondering if you could speak to is, you mentioned diversity and inclusion. So, getting diversity on the Shack committees, is that, how do you go about ensuring that?
That's a challenge. One of the things that we've found that's really important is to be able to have translation available so that you can include your non-English speaking parents. There's different ways to do that. You can have a translator on site. They do have headphones that you can use where you have one translator and the parents can wear those. But I think it's really important to be able to recognize the language barriers and focus on that. Also taking your SHAC meetings to the communities, have a SHAC meeting in a community school rather than having them someplace where it's really challenging for parents to get there. The virtual SHAC meetings has really helped, I think, get a lot of parents who couldn't participate before be able to join in via Zoom or whatever platform you're using. So we've seen some areas where the parent participation really has risen substantially, and that's kind of exciting.
Yeah, sort of a silver lining of all of this virtual stuff. Well, thank you so much, Michelle, and thank you for all of our steering committee updates. I hope that you can see that we do have a lot going on around Texas regarding efforts to reduce obesity. And next up, I'm going to hand it back over to Dr. Leah Wiggum, my co-chair, who will introduce our next portion of the summit. So we'll have a panel and presentation from the Partnership for a Healthy Texas.
Thank you, Emily. Let's see here. Next, we are going to have the next segment of our summit is going to feature a presentation from Dr. Amanda Hall, Associate Commissioner, Community Health Improvement Division for the Texas Department of State Health Services, followed by a Q&A panel featuring panelists Stephanie Kellum, Director of Wellness and Community Engagement at United Healthcare, Tanwir Kalimullah, Program Officer at Episcopal Health Foundation, and Mary E. Gonzalez, State Representative for House District 75, right here in El Paso. This panel will be moderated by Clayton Travis, Director of Advocacy and Health Policy for Texas Pediatric Society. And we're thrilled to have Clayton with us here today. I have the privilege of working with Clayton at the state level, and I've learned so much from him. So Clayton, I'm happy to turn it over to you now.
All right, well, thank you so much. I appreciate it, Dr. Wiggum. This has been a great presentation so far this morning. I've really enjoyed what we've been hearing and all the work going on across the state. Speaking of the state, we are excited to have an initial presentation, and then again following, we will have a panel discussion for some experts and of course a state representative with us on the state of obesity and how can we make policy work in this state. But first, we are so excited to have Dr. Amanda Hall with us. She is the Associate Commissioner of Community Health Improvement at our Department of State Health Services. They have been doing heroic work over the last 2 years, fending off the COVID-19 pandemic, ensuring that all Texans are safe. But many people don't know that they also have a role to play in chronic disease prevention as well, keeping all of us safe from every ailment that may face our population here in the state. So it is my distinct pleasure to welcome and introduce Dr. Amanda Hall. Again, she serves as the Title V Maternal and Child Health Medical Director and previously served as the Title V Children with Special Health Care Needs Director at the department. She's a faculty member of the DISH's Preventive Medicine and Public Health Residency Program and serves as a mentor in the University of Texas Health Careers Mentorship Program. We're excited to have Dr. Hall, and I will hand it over to you.
Thank you so much, Clayton, for that introduction, and it is a pleasure to be here with everyone today. I really am grateful for the opportunity to speak on the state of obesity here in Texas and the work that our agency and our division is doing to address this chronic disease. Next slide, please. All right, and next slide, please. So as an overview, I'm going to be discussing the state of obesity in Texas by focusing first on prevalence data. I will then focus on obesity prevention initiatives within 2 of our division sections, health promotion and chronic disease prevention and maternal and child health. And lastly, I will talk about future plans for obesity prevention. Next slide. Ongoing surveillance and data analytics drive all of our efforts towards promoting healthy behaviors, healthy communities, and a healthy Texas. I will briefly discuss with you findings on the prevalence of obesity from the most recent Behavioral Risk Factor Surveillance System and Youth Risk Behavioral Survey data for Texas. Next slide. The prevalence of obesity among adults in Texas has been rising steadily over the last 10 years. In 2011, 30.4% of adult Texans were obese, whereas in 2020, 35.7% were considered obese. According to the Centers for Disease Control and Prevention, or CDC, Texas had the 12th highest obesity rate in the United States in 2020. When compared with adults at a healthy weight, we know that adults with obesity are more likely to experience a decreased quality of life and an increased risk of developing serious health conditions, including hypertension, type 2 diabetes, heart disease and stroke, sleep apnea, breathing problems, and even some cancers. Next slide. Looking at Texas adults between the ages of 18 to 64, more than a third are considered obese, with a prevalence of 36.4% in 2020. Obesity is more prevalent among Black and Hispanic adults in Texas. 43.4% of Black Texans and 40.7% of Hispanic Texans are considered obese, compared to 32.6% of white Texans and almost 21% of Texans who reported a race and ethnicity other than white, Black, or Hispanic. Geographically, Public Health Regions 1 and 11, which you can see here on the screen, have the highest prevalence of obesity, with nearly 50% of the population in Region 1 considered obese. Public Health Region 7 has the lowest prevalence of obesity in the entire state at 29.1%. Next slide. In 2019, Texas had the 11th highest obesity rate among high school students in the nation, with 16.9% considered obese. There were significant differences by sex, with 20.6% of males considered obese compared to 13% of females. Additionally, significant disparities existed by race and ethnicity, with more Hispanic and Black teens considered obese compared to white teens and teens of a different race ethnicity other than white, Black, or Hispanic. Next slide. Now that we have reviewed the prevalence of obesity, let's turn to the prevention initiatives that are underway within our division's Health Promotion and Chronic Disease Prevention section. The Obesity Prevention Program uses available prevalence data to identify priority populations and communities across the state to implement evidence-based initiatives across the lifespan. Next slide. Each of these prevention initiatives prioritizes the strategies for implementation outlined in the Obesity Prevention Program's 2016 to 2021 Priority Strategies document, which can be found at the webpage listed at the bottom of the slide. These include improving healthy eating, active living, and access to preventive services, while also focusing on work sites and childcare settings. Next slide. There are 3 Healthy Child initiatives I would like to highlight today, designed to provide our youngest Texans with tools for learning and adopting healthy behaviors. The Outdoor Learning Environment, or OLE Texas initiative, works to enhance the design and best practice in childcare outdoor spaces. This can be creating looping pathways, sloped hillside spaces, and natural elements to increase physical activity. We currently have 4 local coalition chapters across the state in Lubbock, Austin, Harris County, and Dallas-Fort Worth. And we have an additional coalition joining us in San Antonio. Our child and adult care food program, or our CACFP Central Kitchen in Harris County, works in concert with child care centers, sponsors, and central kitchens to provide balanced prepared meals for child care centers in priority neighborhoods. We've been able to reach 16 child care centers interested in enrolling in the program for reimbursable healthy meals. The Texas Healthy Building Blocks Recognition Initiative aims to recognize child care centers for meeting best practices in the domains of breastfeeding and infant feeding, child nutrition, farm to child care, oral health, physical activity, outdoor play and learning, and screen time. Our pilot of this initiative engaged 34 child care centers, and we are now targeting an additional 15 child care centers for potential recognition. Next slide. These initiatives are made possible with the support and commitment of dedicated stakeholders and partners across the state. The Early Care Obesity Prevention Work Group that was established in 2017 is one such critical collaboration. This group of partners was instrumental in implementing a standard set of best practices for obesity prevention in early child care and education centers identified in the Caring for Our Children 4th edition, a repository of evidence-based health and safety policies and practices for child care centers. This informed the adoption of Senate Bill 952 in 2019, which requires child care centers to meet these standards and the Child and Adult Food Program nutrition standards. The new standards included in SB 952 impacts approximately 14,250 early care and education centers and over 1.1 million children across Texas. The collaboration of our Ole Texas leadership team is also critical for implementing healthy child initiatives. This team is comprised of 25 stakeholders and thought leaders representing the education sector, childcare, design, landscape, and horticulture. Members of this group connect state and local resources for the improvement of outdoor learning environments at childcare centers in Texas. The Obesity Prevention Program also works with our Healthy Texas Mothers and Babies program within the Maternal and Child Health section to increase lactation support in maternity care, work sites, and communities. As we know, breastfeeding is a primary prevention strategy for childhood obesity and starts a child's life with optimal nutrition and development. Next slide. We are also committed to improving communities where adult Texans live, learn, work, and play. The focus of these healthy adult initiatives is on establishing bidirectional referral mechanisms between clinical and community sites for chronic disease prevention and management. To date, over 120 referral partnerships have been established, resulting in 4,653 total referrals made. There is also a focus on promoting the CDC food service guidelines and work sites and food banks, which has the potential to improve access to healthy foods for over 800,000 Texans. Developing coalitions among public health and planning partners and local communities to integrate infrastructure improvements into community plans is also very important. These built environment improvements connect people to everyday destinations, supporting safe access to active transportation and physical activity designed to impact residents in at least 12 priority communities across the state. There's also a focus on providing nutrition education through our local health department partners to SNAP eligible individuals, which positively influences the nutritional choices of almost 700 Texans. Equally important is modeling worksite wellness to improve the health and productivity of 144,655 state employees in 174 state agencies through our annual fitness challenges such as the Get Fit Texas Challenge. There is also access to weight management programs and informational resources to support healthy living, physical activity, stress management, preventive screenings, tobacco prevention, and breastfeeding. Next slide. Collaboration is also critical for implementing healthy adult initiatives. To identify the best avenues and resources for promoting food service guidelines and work sites, we convened our first meeting of the Texas Food Service Guidelines Partner Coalition in June of 2021. This coalition is made up of 20 representatives from local health departments, business groups on health, hospitals, food distributors, and food service vendors. Additionally, we partner with the Texas chapter of the American Planning Association to help connect people to everyday destinations in the communities of Tyler, Paris, and Mathis. Other key partners include the Texas Public Health Association, Bike Texas, and the Texas Healthy Communities Program. Next slide. A priority population emerging during the COVID-19 pandemic has been older adults. We've partnered with local health departments to pilot initiatives in communities that improve social connectedness for older adults through physical activity. Food banks have also worked to expand access to emergency food resources by creating new distribution sites and implementing home deliveries with SNAP education applicants. Next slide. Maternal and Child Health section also addresses obesity through a life course approach. The life course approach emphasizes the important role early life events play in shaping an individual's health trajectory. The interplay of risk and protective factors such as socioeconomic status, toxic environmental exposures, health behaviors, stress, nutrition, and all influence health throughout one's lifetime. Next slide. We're going to be focusing on two areas today within maternal and child health, and that is our Healthy Texas Mothers and Babies program, as well as our child and adolescent health programming. Next slide. The Healthy Texas Mothers and Babies program implements maternal and infant health initiatives to reduce or prevent obesity in women of childbearing age and their infants. As you can see here, there are several breastfeeding support initiatives, including the Texas Lactation Support After Hours Hotline that provides clinical lactation resources to both mothers and their healthcare providers 24 hours a day, 7 days a week. The Peer Dad Initiative helps fathers understand the importance of mom's breastfeeding success for both mother and baby, and provides ways for fathers to actively support the breastfeeding mom as part of her larger support network. I also want to highlight the Texas Hear Her campaign, which is Texas's newest maternal health and safety campaign to increase awareness about prevention opportunities for maternal mortality and severe maternal morbidity. The campaign's website and materials will include information about health risks associated with unhealthy pre-pregnancy weight, as well as information about healthy weight gain during pregnancy. Next slide. Equally important for obesity prevention is the Child and Adolescent Health Program, which focuses on children and youth, including those with special healthcare needs. The Texas School Physical Activity and Nutrition, or SPAN project, monitors body mass index trends of school-age children in the 2nd, 4th, 8th, and 11th grades within ethnic, gender, and geographic subpopulations using a statewide surveillance system. SPAN is funded by DSHS and conducted by the University of Texas Health Science Center at Houston and Austin, and more information on this project will be shared in a session later today. Focusing on nutrition across the life course, the Maternal and Child Health Nutrition Toolkit increases each public health region's workforce capacity to address obesity in children, adolescents, and children and youth with special health care needs. Resources include a presentation template and implementation manual, statewide and regional data, and health promotion materials and program evaluation resources. DSHS also provides funding to the Texas Juvenile Justice Department in support of the Physical Activity and Recreation Initiative known as Stronger Than Yesterday. The goal is to operate a well-rounded exercise program for youth living in residential facilities. This includes a variety of physical activities, support groups, regulation games, team building activities, and therapeutic recreation. By providing at-risk youth with the tools for establishing a healthy lifestyle, the theory is they will take these lessons learned when they return to their homes. The Maternal and Child Health section also funds the production and dissemination of a parent's resource guide to raising happy, healthy children. This guide provides parenting tips by age, including information on nutrition and physical activity appropriate for the child's age. The guide is available for free to providers to distribute to their prenatal care or delivery patients who are enrolled in Medicaid. Next slide. In terms of future plans, our Community Health Improvement Division at DSHS understands the lessons learned from the COVID-19 pandemic on disease risk and outcomes and the need for obesity prevention initiatives. We're excited for the potential identification of new partners and evidence-based practices. Next slide. Health Promotion and Chronic Disease Prevention is looking forward to the statewide expansion of our Texas Healthy Building Blocks Recognition Initiative to all interested child care centers across the state of Texas. We are also preparing to launch the OLE Texas Quality Seal for child care centers that meet design practices. We are also planning to assist child care centers with enrollment into the CACFP Central Kitchen to increase the number of children who consumed healthy meals daily. Next slide. To ensure our obesity prevention efforts are focused on the most timely and innovative practices with the most critical partners, we are also updating our priority objectives document for the next 4 years. And additionally, as our obesity prevention program's five-year cycle of CDC funding comes up for renewal later this year, we're looking forward to learning of and working on the most current and critical obesity prevention strategies identified at the federal level. These strategies will undoubtedly influence the landscape of obesity prevention efforts in Texas. Next slide. So thank you again for the opportunity to present today on the state of obesity in Texas. Recognizing that obesity is one of the most prevalent chronic diseases in Texas, we remain committed to prevention as we work together with our stakeholders and partners to address obesity across the state and across the life course. If you're interested in connecting with our obesity prevention program and would like to learn more about what I've discussed today, please feel free to look at our website, or you can email us at the email on the screen. So thank you very much, and I will turn it back over to Clayton.
Well, thank you, Dr. Hall. That was a wonderful presentation. We appreciate you providing such a wealth of data and talking about the various interventions and programs you have going all across the state. It struck me how much collaboration is going on with DSHS amongst community-based organizations, local public health. I was curious if you could just add on a little bit about maybe how you might collaborate with other state agencies. You talked a little bit about that in the Get Fit program. But, you know, with the Health and Human Services Commission, the Medicaid program, which serves more than 4 million Texans now and provides health care to those individuals, what ways is DSHS and your division really collaborating with those state agencies?
So that's a really good question, Clayton, and it's a very important one because one agency cannot work on an initiative alone. There are different parts of it. We come to things from a public health perspective, but as you are very well aware, there are direct client programs. And so we have as an ability at public health to provide data and be able to provide that public health approach. We really can, I think, expand our reach in the things that we do. We coordinate with Health and Human Services on a variety of initiatives. We work with Dr. Van Ramhorst through the Office of Medicaid, and just really have opportunities to kind of collaborate on some of the different initiatives. I can tell you, for example, within maternal and child health, we do a lot of work with them around maternal mortality and morbidity, looking at opportunities around intervention, not only for those, looking at those kind of chronic diseases that we know impact maternal health.
Thank you for that. FYI, everybody, please go ahead and submit your questions so we have a few more minutes to ask audience questions of Dr. Hall. I do have one here for you, maybe a comment. It's a question as well. There's a concern that there's such low participation statewide in the YRBS survey. So I'm wondering, the question is, I'm wondering if there are other strategies you are thinking of to look at the prevalence data statewide. How do we get a better representation of
So I think those are really good questions. And I think some of what we have to do is to think about coming out of the pandemic and what we have learned through the pandemic and how that has impacted some of those different things that we do. And so I think going back with the team and kind of looking at that and looking at it with our partners as an opportunity to look at some of those different prevalence data and how we can approach that.
Thank you for that. Any more questions from the chat? Give it just a few more seconds. And while we wait, I do want to commend y'all on the excellent feedback email that you have there. Bringing healthy back, I think, should be a theme for the entire state. I like that. And I will commend the agency for the work that they did. I know you mentioned Senate Bill 952 in your presentation. I was a member of the Early Care Obesity Subcommittee that DISH has put together, where we did a lot of brainstorming, both on the policy side, but also on the program intervention side. And SB 952 was a policy priority for the Partnership for Healthy Texas. So very glad that we had that collaboration from the state, and then on the implementation side as well, because that was crucial to ensure that so many children, what'd you say, 1 million plus children across the state who are served by child care centers and homes are now have access to those healthy foods and standards within the minimum standards for child care centers. So thank you for mentioning that. Looks like we have no other questions at the moment. So Dr. Hall, I just want to again thank you so much for your time, for your dedication and leadership in these issues. I know DISH has a lot of priorities, especially with the pandemic. We're starting to see the light at the end of the tunnel. Can I say that? Am I allowed to say that, Dr. Hall?
We are seeing things move in a positive direction. Yes, Clayton.
Great. Okay. Well, that's my editorialization. I'll add at the end there. So again, thank you so much, and we look forward to working with you.
Thank you so much, Clayton, and thank you to everybody for being here today.
Great. Well, I'm excited to move on to the next portion of our Partnership for Healthy Texas segment as a part of our today's agenda. So I am happy to moderate an excellent panel of participants on an issue of how to keep obesity policy relevant and the impact of COVID-19 on obesity policy. So we have an excellent lineup of panelists today, which we'll go through. I realized at the beginning of this portion, I didn't even introduce myself. So let me go ahead and do that really quickly. My name is Clayton Travis. I am the Director of Advocacy and Health Policy with the Texas Pediatric Society. TPS is the state association, state chapter of the American Academy of Pediatrics, and we represent over 4,700 pediatricians, pediatric subspecialists, and medical students dedicated to the health and well-being of Texas children. We get engaged on a number of issues on the advocacy front, but obesity is always top of mind for us, ensuring that we are putting preventive policies in place and providing counseling and care and treatment to children who are needed for obesity as a diagnosis. So we're excited to be here, excited to be represented. I also serve as the vice chair of the Partnership for Healthy Texas. You are stuck with the vice chair today. Unfortunately, Dr. David Lakey, previous commissioner of the Department of State Health Services and current chair of the Partnership for Healthy Texas, couldn't join us today. He's a very busy man, but I'll do my best to fill his big shoes and represent our organization as best as possible. So again, moving on to the fun of the of the presentation today. We will be taking questions at the end, so please make sure that you are providing those in the chat, and then we will moderate those questions towards the end. But first, let's get to our panel presentation. I am so excited about who we have here today. And first on that list is Dr. Representative Mary Gonzalez. Thank you so much for being here. Dr. Gonzalez is a state representative of House District 75 in El Paso, as we mentioned. She is the vice chair of the almighty Appropriations Committee in the House and subcommittee chair of various articles as well. She also serves on the Public Education Committee, one of our most important committees in the state legislature. We are also here joined by Stephanie Kellum, Director of Wellness and Community Engagement of United Healthcare, one of our important health plans in the state, both in the Medicaid and commercial space. So excited to get her perspective on how healthcare comes into play when it comes to the treatment and prevention of obesity. And then finally, we have Tanwir Kalamula, Program Officer with the Episcopal Health Foundation, which is an amazing foundation that does funds amazing grant work that we're going to hear about today across the state, but also has an interest in advocacy and policy as well. So thank you all for being here. We're going to start with just self-introductions, if you will. I want to hear from y'all about your day-to-day job, how that relates to obesity and obesity policy, and a little bit about why you're excited to work on obesity or continue working on obesity in the future. So without any more introductions, I'm going to hand it off to Representative Mary Gonzalez. Thank you for being here.
Thank you so much, Clayton, for having me, and to everybody on the panel and everybody watching. My name is Mary Gonzalez. I represent the eastern part of El Paso County. I have been a state legislator for a decade of my life. I feel like it just keeps on going. And in my time, I'm happy now to serve as the vice chair of the Appropriations Committee and on the Public Education Committee. Why am I here today? I was really fortunate to hear really about how this topic is so intersectional to so many other areas of public policy, whether it's healthcare, whether it's health access, education, I mean, so many different appropriations. And so for us to be able to really use public policy that was just common sense just really made me excited to do something for the state. And so really thank you for all of you for your leadership and creating awareness for people like me to make some changes.
Thank you for that. Stephanie, do you want to introduce yourself and the work you do with United Healthcare?
Yeah, so again, great to be here. I'm so excited about the panel and the conversations we're going to have. So I serve as the Director of Wellness and Community Engagement, and I actually feel very fortunate in my position. So I get to work with school districts, schools, and community organizations to help support wellness programming around the community and around students. So traditionally, United Healthcare may be seen more as that staff wellness role, as well as the insurance provider, but I really get to get down on the grassroots level and really support the school districts in understanding what their needs are, and then bring in programs or connect them with community organizations to better their agenda around health. So I've been working with childhood obesity initiatives for the last 14 years, but more specifically around the school health for the last 11 years. I'm a member of several of the school health advisory councils across Texas, and really passionate about supporting that role in the advocacy for parents' voices in giving a voice to them around wellness in their school districts. I also serve as a steering committee member for Texas Action for Healthy Kids, so I'm able to also support that at a state level, and just again, very passionate about the work that we do around health and wellness as well as childhood obesity.
Thank you so much. It's great to see that health plans have that investment not only on the coverage side and the healthcare side, but also in the prevention and community-based side. So we'll talk a little bit more about that here in a bit. And last but not least, Tanwir, would you like to introduce yourself, sir?
Great seeing everybody. I'm Tanwir Kalamula with the Episcopal Health Foundation. I'm a program officer, and I'll be speaking as far as my role and as far as Episcopal Health in a broader level. But I think everybody knows or has seen, we believe in health, not just healthcare, and addressing all these different health issues, and also looking at what are more of these more upstream conditions that are affecting the issues that are, creating conditions like obesity and diabetes, and how can we understand the health outcomes, and how can we also get organizations, either whether through direct grant funding or through advocacy, and trying to position everybody to work on preventing and mitigating some of these issues, especially addressing non-medical issues and root causes that most say fall outside of healthcare. And I think that's a big key part of it. But to do that, you have to, what we try to do, and from one side is to position organizations to better address these, whether healthcare organizations or other, to address a lot of these non-medical and root causes before people get sick from obesity or before these things occur. And then, if they do get sick, also to better, look at these things from a more of a population health perspective to address these things and manage patients who happen to get it. But and as I think, as you already referred to, whether it's like, working with the Texas Pediatric Society or other organizations, encouraging, advocating organizations like yours or ones in healthcare or otherwise to redirect some of these funds, to talk to people, to also redirect some of the funds that are in healthcare otherwise to address a lot of these non-medical issues to prevention and mitigation. And then also, working with a lot of these different sectors, because it's, it's going to take everybody to address a lot of these issues. So that's it.
Thanks so much. I appreciate the work that EHF does in that regard. So let's jump into some of the tough questions that we have today. So first and foremost, we had a presentation in the morning about 4 decades worth of rising obesity rates. We just had a presentation from the Department of State Health Services about constant and upticking obesity rates in the state of Texas itself. And I don't think anybody's kidding themselves here, is that obesity is not necessarily the sexiest topic. It's not on the top of anybody's agenda, whether that's policy or in communities. Sometimes it takes advocates and it takes leaders to bring this issue up to advocate for it. So that's why we're going to talk here today about how do we keep obesity policy relevant? How do we elevate that to the realm of creating impactful interventions? And so, Representative Gonzalez, I was really hoping if you could kind of lay out the landscape of how the legislature deals with issues like this when you have so many competing priorities of things to work on. Lawmakers are working on water and education and healthcare. So what does it really take to elevate a singular issue like this? Obviously, it's multifactorial, but to the level and consciousness of a lawmaker and to the leadership of the legislature.
Yeah, that's a great question, because you're right. So just on background, I'm sure everybody who's watching this knows, the legislature only meets every 200. I'm so sorry, somebody's doing electricity work and now I feel like it's loud. But the legislature only meets every 2 years for 140 days. And so if you think about the limited amount of time that we have to address issues, it can really get caught up. And so what I tell people is 3 things. One is start early. Don't wait till legislative session to have the conversations. 2 is identify 2 or 3 champions, because all of us have our areas where we work. And so that I'm very passionate about it. It'd be nice if I had some colleagues, some on the other side of the aisle as well, who were also equally passionate, who could be our little team to work through things collectively. And then 3, I think what you've already been doing is demonstrating the intersectional realities and the return on investment for doing and advancing this public policy area.
Thanks so much. And would you agree that it's reflected in the difficulties in determining where all the money goes? In our state budget, we can't have debt. We have to balance that budget every session. And so determining which programs, whether at the Department of State Health Services or HHSC, get funding to maintain these important obesity prevention policies is difficult. I don't envy your task, Representative Gonzalez.
It's a huge job.
I'm sorry?
It's a huge job, but I'm grateful for it.
Well, we appreciate your leadership on the issue and keeping this issue top of mind in those conversations. So Stephanie, I was wondering if you could kind of take it from a more community perspective. You talked about your work in communities with shacks and schools. Those entities have competing priorities as well, right? Number one being, how do we educate our children? And so often we hear is, we can't make space for PE, or I can't deal with healthy eating because I got to get kids to testing, things like that. So how do you compete with and keep obesity at the top of people's minds in various communities?
Yeah, so it's really funny because I think about maybe 15 years ago, it was a lot harder to do this, but the research has come out more recently that like healthy kids do better. They learn better, they're more successful in the classroom, they're in school. And so you kind of have to change your language when you're speaking with schools. You can't talk about obesity from a health perspective. You have to talk about it from an educational perspective and really meet your audience where they're at. So I think it's very important to reframe the conversation about, you know, I know that your top priorities are to have kids in the classroom, to have them learning, to have them paying attention. Hey, did you know that healthy kids are going to do those things? The research is here. And so really kind of making sure that everyone understands that the agenda is the same, finding that common agenda, and then setting some shared goals around that is really important so that you're seen more as an advocate and a support to the school district than you are bringing a different agenda item. I think it's really important to meet the school district where you're at, where they're at too, and then seeing what kind of commonalities there are. And I think too, because of COVID, a lot of school districts are really, you know, thinking about this student achievement, loss of learning. And so this is a perfect time to bring all this together to say, you know, don't take that recess away. The kids need that brain break. They need that movement. It's going to re-stimulate them. They also probably haven't been moving for the past year when they were at home doing virtual learning. And so really kind of bringing all that information back together. I think the other big conversation that we're seeing is around mental health and how that ties into obesity as well. That's very top of mind for school districts. And so that's something that, again, you can connect to and really show the bigger picture around how all these systems, as Dr. Gonzalez mentioned, are interconnected. Everything is interconnected. And so I think the biggest thing is it takes time, right? It takes a lot of time, and you can't expect to see instant changes either. So when you're working with these school community partners, you really have to set a realistic timeline to see when can we make some changes, or how can we adapt, how can we meet your needs, and what are our goals together.
Thanks, Stephanie. I appreciate that. And I think it's helpful to lead by example, right? United Healthcare doesn't necessarily have to get into the space, but you as a non-traditional stakeholder within communities and school districts are kind of demonstrating that if you can place this top of mind, then so can other stakeholders who may not be seen as the public health entity in the region or in the state. So I appreciate that as an example. Tanweer, how about you? I mean, in the foundation funding space, in the research that y'all do, there are a lot of different things that you could be addressing. I know you do a lot of great work on healthcare coverage. You do a lot of great work on social determinants of health. So why obesity, and why does that rise to the level of areas that y'all want to work on and focus your efforts?
I mean, I totally agree with you, and thanks for the introduction on that part. Yes, obesity is obviously key to, because if you look at so many of the different chronic issues like diabetes and cardiovascular issues, you can always link it back to some things that are related to obesity. And I think I would say part of the larger story, kind of like, I would say there's two approaches when you're looking at how can we actually put obesity front and center. So obviously, like you had already mentioned, there's the advocacy side and working with organizations who can be putting forth like access. And so you have to remember, this is, you know, sometimes there's obesity direct and there's obesity as part of a package. And I think that's part, you know, to make sure, because at the end of the day, what we're wanting to do is affect the people and get them into a better place and have improved health outcomes. So however the packaging is, that's the main thing. So obviously, you know, there's the part, as you mentioned, there's a lot of research and studies that we put out, there's studies we'll share. So that's one of it. So that's kind of like the nudge effect. You know, how can we nudge people towards thinking about, you know, influencing people? And that's one of those things where you have to have constant touches. And then other part is working directly with partners. So for example, working, you know, locally with like Healthy Living Matters with Harris County Public Health and all the partners who work there. Or Michelle was on earlier, you know, working with people like her or the Health Equity Collective. So working with partners who are thinking about obesity and have it as part of their goals. So, you know, Episcopal Health engages organizations who then do the work. And it just is, you know, on the advocacy side, as you mentioned, there's access. There's also the aspect of whether we're talking about advocacy or the clinics, as Stephanie can speak more to this as well, the value-based care aspect. You know, there's, you know, trying to encourage that particular piece and trying to like get people who are working not only in healthcare spaces, but other spaces to be thinking about the quality of how do we interact with our clients and our community members, and not just the outcomes and value-driven type of work, and positioning organizations to do that. But I do also want to this is also a story, kind of like what you said, there's like so many stories, like since like when the pandemic started, there was a lot of great opportunity, and there was a lot of education that people got that I think all of us in the healthcare and public health realm could never have done if not for the pandemic. I think people can understand that. But as far as looking at these non-medical factors of social determinants of health, if you look at like people who are if you take a story, everybody has there's one of the things that makes it difficult is people sometimes consider obesity a choice. I think that's an issue that we have to all deal with, and that there is an aspect, and I think nobody can deny the agency is part of it. But how can we make people create an environment where there's better choices that they can make? And like incentive, and so it's not just about choice, there's other things like there's an environment. So for people who live in, middle income or high income, to have a bigger space in which they can go ahead and have choices, and other people who have other conditions, they have a smaller zone of choices. But I think the pandemic was great because you saw a lot of people who experienced for a brief period of time limited choices. And what did they do? They turned to they had the only thing they had access to create some level of joy sometimes was eating, or they had to, or even just, they were more constrained. So they also, they had some, as everybody knows, that obesity and mental health issues were climbing. So I think taking those types of stories when they occur and being able to and carry those and keeping those types of stories alive, because if you don't take those opportunities, it's still gonna it'll get lost in a lot of the other news stories that come through. And then also being at the table. If you're not at the table out of these places, these things are just gonna die. So
thanks for that. I appreciate that, and I appreciate the discussion about bias. I think that builds into our keynote presentation we had this morning. What is the reason that people are obese? It's because of choices, and it's their individual responsibility. So, Representative Gonzalez, I wonder if you could build on that a little bit. What do you see in the political realm on that kind of ethos of political responsibility, and where the state can step in to provide public health intervention? Where, what is our responsibility to our fellow citizens versus that political and personal responsibility that is touted at the Capitol as well? Not an easy question, sorry.
Yeah, I thought we were gonna give me softballs today. I haven't even finished my second cup of coffee yet. No, but I think what I really, I'm grateful for the conversation, because I think that is one of the biggest barriers to creating advancing public policies regarding obesity is the assumption that it is a choice, right, as opposed to a disease or some. And so I feel that there's two things for y'all to consider. One is folks that are in the decision-making chairs, at least this upcoming session, are going to be a lot of new folks. So we've had a huge turnover post redistricting and elections that are coming up. And so it's a great opportunity, but it's also a deficit, right? I know a lot of y'all have been building these conversations, and you're finally getting some awareness and traction. And now there's a third of the legislature who's going to be new. And so we have to start all over again. But nonetheless, a great opportunity for folks to really come in and understand some of the things you're talking about and building a different narrative that will that challenges maybe their assumptions. But there is an ideological factor that you all have to navigate as you're building this narrative. There is the ideological reality that there are folks who feel that personal responsibility trumps all else, especially in the public policy realm. So feeling that obesity is a personal responsibility as opposed to a public reality and public need is a shift that is not only a consciousness shift, but an ideological pinpoint to think through as you strategize through advancing public policy.
Thank you for that. And I know it's a tough one, but it is a reality. And I go back to thinking about how we deal with cancer in the state. There's a huge amount of cancer research investment in Texas, and we deal with that as a disease. And there isn't really a lot of talk about personal choice as it relates to cancer. And yet we do in the obesity realm. And if we could take that same slant as to how we work on cancer issues, I think we would make a lot of progress at the state as well.
Can I give an example though? And do you want to go first, Doctor? I'm sorry, I know you wanted to say something. I will say one thing that I think has been really helpful in advancing funds in regards to cancer is really connecting that personal narrative. So when you saw Representative Kyle Casal talk about his family member, when you saw Representative, oh my God, Kemple talk about his family member, like you would see like, so one way I think we could advance this is using personal narratives and research about obesity as a disease, and I think it could be really transformative. Sorry, doctor, I know you were going to add on to that.
No, and I'm not a doctor. I only play
My
one.
apologies.
No,
He's a JV,
no. My
completely
mom would
different.
be happy. My mom would be happy to hear it. There's no problem. I just want to add one thing, because this has been a phenomenon that's occurred during COVID. I think, I think a lot of us have seen a lot of these people, and again, there's a room for this, but you see a lot of people are focusing on, especially with people who've been affected by COVID, and all these the people who are more prone to get more immunocompromised because they have certain health issues or chronic health issues. You're seeing a lot of people like, if people will eat better and exercise, they won't be affected. And I think that's part of a story that we can build is, there is a short term and there's a long term strategy. In the short term, that's not going to help people with chronic issues right now. We need to help create a better environment for them and give them resources, give them access, improve obviously with the long lines with food access, food security, and housing. But there's also a long term strategy, and that is where we can tap into that type of thinking, but creating to create a long term strategy when we're working with elected officials and businesses and other types of organizations. So.
I appreciate that. I was wondering, Stephanie, you're probably the closest out of all of us here and working directly with families and community members. What would you suggest to individuals who are listening today about how to get engaged in kind of, when I say policy, people get intimidated. They think of the state legislature, they think of testifying, but there are also ways to get involved at a community level to influence local policy or on the matter. So what would you suggest people do to get involved?
Yeah, absolutely. So I know earlier I mentioned the SHAC, the School Health Advisory Council, and that's a fantastic way for individuals, whether you're a parent or you're a community organization, to get involved at a local level. So the SHAC is mandated across the state of Texas. So every school district has to have a SHAC. And a SHAC, the goal of the SHAC is to be a majority parent population, so you can have a really diverse representation of your community, giving opinions to school policies. And one of the major policies that SHACs have stake in is a wellness policy. So all school districts are mandated to have a wellness policy, which until the last couple of years, I don't think anyone had touched. But because of a reauthorization act, all school districts were required to bring that off the shelf and to revisit it and to reevaluate what their wellness policy looked like. So there are several ways that families can get involved and really give your opinion. And I think not being scared of maybe not knowing everything is important, because we need those diverse opinions. We need those stories. I think the biggest thing I've been taking away from COVID is the stories. We need to hear what's happening at the campus level, especially from those that don't have much of a voice. So, in our Title I schools, it's very hard to get parent participation on our SHACs, but we've leveraged parent educators that exist at those campuses to give the voice of those parents. So again, amplifying the stories of those that maybe not have a voice currently, and then looking at ways to give them a voice, to teach them to be advocates for their community, for themselves, and to show them the way to get involved at a very low level if it needs to be, or at a larger level. So one of the things that one of the SHACs that I'm a part of created this past, I guess, almost now a year ago, was an advocacy subcommittee. So we could be better prepared for the next legislative session, because we realized we kind of missed the last one. So as you noted, get prepared ahead of time and really then educate our constituents on how they can be good advocates and how we can support our legislators in the area, so they're aware of what SHACs do, what's happening at the school level, and then what should be those priorities for those representatives.
I love that, because so much of what is done at those SHACs is controlled by the laws passed at the legislature, votes that Representative Gonzalez and others have taken on these exact bills. So it's important to get involved locally, but then you can kind of scale up, if you will, and impact the entire state. So I appreciate that. We are going to be taking some audience questions here in a little bit, so please send those via the chat. We want to make sure your voice is heard in this discussion. The last question I'll pose to the entire group is, really focusing in on COVID. We have talked about it a little bit, but where do you see as the policy opportunities, the policy windows, as it relates to the overlap between COVID and, obviously we want to talk about obesity, but maybe some other areas as well. I think Stephanie mentioned mental health is going to be a key thing there. So there's a lot of overlapping layers here. So what opportunities do we have in the next legislative session. And for those who don't know, that starts in January 2023, but a lot of the lead up is going on right now. So what opportunities do we think and we have in the policy space to really tackle the overlay of COVID and obesity? And we'll start with Tanweer, see if you have any thoughts.
I would say, probably when you're looking, there are a lot of opportunities that are one particular area. Obviously, looking at Medicaid is one particular area, and I think there's just a lot of things that have been turned on at the federal level that we could turn on here at the local level. That's part one. I think this is an issue with all states. For example, I think kind of going back to what you're talking about at the community level, I think a lot of this work needs to be done at the community level. But to do that, you need to have people who can be the voices, and people who can actually get the voices out and actually be able to communicate inward. And I think, as we all know, people like physicians or people like community health workers are key in a lot of these discussions. And organizations, you can tell that they're bursting wanting to hire community health workers, but there's the funding aspect. A lot of this goes back to resources. I think one of the earlier questions, like, how can we keep this? But we have so many conflicting things, and organizations, whether you're nonprofit or healthcare or whatever, they have limited resources and capacity, and you have to be able to pay to be able to initiate strategies and to have people who can carry out these things. And so if we can create opportunities for that through through Medicaid or through some other incentives, and there's the business sector as well. What can the business sector do for their employees? Because we have to remember, a lot of these people are employed and they're working in places, and business can also do that as well. So I think that is one particular approach to doing that. And also, one other way, and this is not necessarily through government, but we want to also not be create more of a positive aspect, more of like a positive atmosphere. It's easier for people to want to be healthy or to want to lose weight, or as opposed to trying to say you should be doing this. That's two different phenomenon. So if you look at a lot of the nutrition movement, a lot of those things are, we can make fun of a lot of the Whole Foods and these types of things that come to neighborhoods, but there's a certain level of like a mindset that people are in, like, oh, I want to kind of be part of that. And what can we do to create more carrots and incentives? And so that means creating environments around people, like, governments can do this, local and state, and beautifying neighborhoods in terms of creating beautiful parks and putting these things in. That's where I think governments can do, and creating places that will incentivize people on their own to go do the things without telling them, oh, you have to do this. Or they can be, obviously, another one on a broader level, and this is people who are much smarter than me on this, is a campaign. You have Don't Mess with Texas. Nobody talked about, what that meant, but it was just so effective in terms of turning around the littering and everything, and the environmental issues. And if we can have these things that can actually get to people and behaviors and getting them thinking in a certain way. So.
Thank you. That's what I'm saying. That email box from Dishes about bringing healthy back. I think that's your slogan right there. That's what we need to go with. So, Stephanie, same question. Kind of what opportunities do you think we have in the next, either the next legislative session or next few years, as it relates to addressing obesity and utilizing kind of COVID as that messaging point?
Yeah, well, I think it's really important to also think about what has happened in the last couple of years, and is there something we can capture from that? Are there some stories, some best practices, some opportunities that worked that we can build upon? Because I think, this is a new world that we're in now, and we've exposed a lot of inequities around what, people need. And I think we need to capitalize on momentum that's happening now, because this is the new world that we're living in. So really kind of finding out what those best practices are that work during COVID, and how can we build upon those. I also think, like Tanweer mentioned, if we can reframe the way we approach obesity from a different aspect that has more meaning to the individual, like I talked about earlier, when I talk to a principal, I'm not going to talk about health, I'm going to talk about education. So we need to talk about obesity in a different perspective when we do national or statewide campaigns. We need to reach our audience in something that's meaningful for them. And so reframing that story and that conversation to meet what the audience needs is very important. I think that would have success in kind of future growth and how we look at this epidemic.
Thanks so much. Representative Gonzalez, any last thoughts to bring us home on where you see us addressing obesity in the future? What opportunities are out there?
Yeah, so I think three things. One is I think really using the intersections of mental health and obesity is a way to really propel public policy, because it's such an issue that is so luckily not as not as partisan as some of the other issues, and so really using that as an opportunity. Second is there's still a lot of federal funds and we'll have an increased revenue. So I would think that we should be really strategic about resources and specifically using the words return on investment. So if the state were to invest $1 million, here's a ways in which we would feel that return on investment. And I think that appropriators specifically love making those types of investments. Mm-hmm. And then third, I will say, and this is something that's different, but maybe something for your community to consider, is that in the past, public education was very central to the legislature. We are hearing very frequently that it's going to be a higher education session. So thinking through maybe different research ideas or different centers or different collaborations with universities and communities. But knowing that there's a lot of energy around it being a higher ed session, that's still a little bit too early to predict, but there's lots of conversations early on about that. Might want to think through what are ways that we could be really intentional about capturing that higher ed session if it does actualize.
That is a great idea, and one that maybe we haven't given enough discussion about. How do we really think about improving the lives of young adults and in their college lives experiences, and then also how do we utilize some of our best in the world universities and research institutes to kind of inform the work we're doing. So thank you.
Or can I just give an option? Like, there is a lot of energy for rural work, right? So like rural community colleges, rural colleges, junior colleges have a lot of place in local communities. And so how is there some partnerships that are available? I'm just, not to tell y'all what to do, but there's some ideas.
No, I appreciate the spitballing, and these are some great ideas. You're doing well to represent your district as well, so we always appreciate that. We do have one question from the chat, so keep them coming if you have any additional. We'd love to take advantage of the expertise on the panel today. I believe this is for you, Stephanie. So are there school counselors involved in these conversations within shacks? What does that involvement look like?
Yes, so actually our gold standard for the shack is to model it around the whole school, whole community, whole child model. And I know that's a mouthful, but within that model, we try to bring in all different aspects. So the school counselors are involved in that conversation, child nutrition's involved in that conversation, even facilities because of the environment. And are we cutting the grass so the kids can go outside and play? So we try to be very coordinated with our approach in the shack so that everyone has a seat at the table and those programs and needs and conversations are happening in a collective model. And that's really been actually a highlight of COVID. A lot of our meetings went virtual, and so lots more people could join. Oftentimes we couldn't get people from the campus to these in-person meetings that are happening during the school day. And so some of our meetings now have grown to 75 participants, a lot from the district, because they're able to share information and then also get that information out. And so a lot of times there's connections that are made. Oh, that's a program that we can pull into our campus. But yes, long story short, yes, counselors are definitely involved and a crucial component of these conversations around the shacks.
That's excellent. I appreciate that. So we have a couple more questions. Unfortunately, we're gonna have to pick and choose just due to time, but I got a question here. Do you think is any scope for legislation to increase funding for obesity research in Texas, echoing the investment that is made in cancer research? I think we talked about that a little bit. Representative Gonzalez mentioned that there will be some revenue to work with next session. That's the beginning, potentially. Maybe I don't want to count my chickens just yet, but there may be opportunities. So is that something that we could look into? And you mentioned higher education, maybe there's a collaboration there. What are your thoughts on that, Dr. Representative Gonzalez?
Mary's fine. But anyways, so I will say this, we are building the base budget now. And so I would specifically talk to agencies if you maybe want to do a tri-agency type of work, if you're thinking about maybe HHS and I don't know, Texas tech system, right? And I think thinking through there's a lot of also energy to go beyond the traditional UT A&M. And so if you saw in the last round of federal funds, there was $100 million given to the University of Houston and Texas Tech. So my point is, like, there is going to be additional funds. We know that's going to happen. So let's think strategically over what could we potentially be asking to be put in the base budget. Are there riders that we can talk to the appropriations leaders to already be putting in? And is there some agency collaboration that they could support advocating on their own for? Happy to talk more about this online because this is like super in the weeds about appropriations, but it's kind of my exciting topic. And now I finished my cup of coffee, so I'm ready to have it.
Maybe not everybody, but I appreciate the insight. I mean, that's exactly what we want to hear, is that there are venues to have these discussions, and the more engagement we have, the more thoughtfulness we bring to the table early on in the process, the more we can have some results later on during session. So I want to thank the panel. There are more questions, and maybe we can answer those at a later date, but we don't have the time right now. Thank you so much for being here, everybody. Representative Gonzalez, Stephanie, Tanweer, we really appreciate your time and your expertise, and thank you for your insights.
Thank you. Appreciate it.
Absolutely.
Yeah.
Well, we have in the last 2 or 3 minutes of the presentation, we did want to kind of go over a little bit more about what the Partnership for a Healthy Texas is. Why am I here talking to you about it? And as you can see on the slide here, we have our mission, and that is, quite frankly, to develop and promote state policies that prevent and reduce obesity. We talked a lot about the different areas for policy making here. There's local policy, there's foundation work that's being done, there's direct services. But our role, and we try and keep it as narrow as possible so we can be as effective as possible, is to pass bills and legislation and work with state agencies to prevent and reduce obesity. Again, finding what works, so filtering up those best practice interventions, that clinical research, setting our priorities. We have a vigorous legislative priority process before every session that's going on right now, which we develop. We work amongst our partners to develop what we want to do, and then we present that to the legislature and do our best to pass legislation like SB 952 that was just discussed, like some appropriations from last session that we were successful in getting, and then we follow through, make sure that when it's implemented correctly, that it's having an impact on what the ultimate outcome, again, reducing and preventing obesity. So next slide, if you don't mind. Just to give you a hint here, just to give you a picture of who all participates. We are a coalition of organizations, so not so much individuals getting involved. We really do want to represent organizations who represent individuals. And so as you can see here, we've got a large diversity across the various stakeholders, everyone from the Texas PTA representing school and parent voice to every disease group you can think of, from the Diabetes and Heart Association. We have built environment groups about like Bike Texas, who are all about making sure that our communities have the ability to live in a healthy fashion, to think tanks like Every Texan and Children at Risk and Texans Care for Children, whose #1 priority is to figure out what best policies exist out there in other states and then pass those here in Texas. And then your healthcare sector as well. So the Texas Medical Association, my organization, the Texas Pediatric Society, and others are at the table making sure that we are doing what's best for Texans. So moving on to the next slide. Oh, and I do want to first, before, if you don't mind going back just a second, sorry about that, I do want to give a huge shout out to the Methodist Healthcare Ministries of South Texas. The work that we do is supported by their generous donations and our grant funding, and we want to just say how grateful we are. We would not be as effective or efficient in the work we do without their support. So thank you to MHM. Next slide, please. And then finally, how do you get involved? So if you are an organization on this call today who says this is right up our alley, or we have a section of our programming that is dedicated to reducing obesity, we have inputs as to what kind of laws need to be passed at the state legislature, or what kind of interventions need to be promoted by state agencies, get involved. Go to the partnershipforhealthytexas.org. We think we have a great website that highlights what we've done in the past. There's a list of legislative priorities. We have an entire report that we created towards the tail end of last year that incorporates the impact of obesity on COVID and COVID on obesity, and legislative priorities looking forward and what we were able to pass last session. So a wealth of information on our website. And if you scroll down to the bottom of that very first page, there's a form you can fill out to sign up for our listserv, to get monthly e-news as to what's going on in this space, and then get connected to further work to promote our policy priorities and to come to the Capitol and lobby right alongside us. So, and then of course, follow us on our social media channels. We'd love to get you engaged in that way. So thank you again for having us. We appreciate Live Smart Texas and Dr. Wiggum for having the Partnership for Healthy Texas represented here today, and look forward to working with everybody here in the future. Thanks, everybody.
And Thank you, Clayton and panelists, for a wonderful discussion on the state of obesity in Texas. And we will now move on into our last segment of the World Obesity Day Summit with presentations from Claire Naday, Child and Adolescent Health Group Manager with DSHS, and Dr. Deanna Hoelscher, Regional Dean at UT Health School of Public Health in Austin. Their presentation is titled Texas School Physical Activity and Nutrition Survey, Translating State-Level Obesity Data into Public Health Impact. Claire is the Child and Adolescent Health Group Manager with the Maternal and Child Health Section at the Texas Department of State Health Services. And in this role, she oversees initiatives for children and youth ages 1 to 24 as part of the state's Title V Maternal and Child Health Services Block Grant Program. These initiatives focus on the health topics of optimal child development, injury prevention, secondhand smoke exposure prevention, and also obesity prevention. Dr. Hoelscher is the Regional Dean of the UT Health School of Public Health in Austin and the Director of the Michael and Susan Dell Center for Healthy Living. She is Principal Investigator of the Texas School Physical Activity and Nutrition Survey, and that's funded by the Texas Department of State Health Services to monitor the prevalence of obesity in school-aged children in the state. And the STREETS project, also NIH-funded natural experiment to determine the effects of safe routes to school policies on child physical activity. And along with her role as director of the Michael and Susan Dell Center for Healthy Living, she oversees the Texas Research to Policy Collaboration Project. So please join me in welcoming Claire and Dr. Deanna Hoelscher.
Thank you so much. Deanna, did you want to get us kicked off?
So I think we'll start with Claire. So she'll give kind of the background before the background for SPAN and how we intersect with DSHS, and then I'll go into a little bit more of how we use the data from SPAN.
Great, thank you. Well, good afternoon, everyone. I know that you heard earlier today how important obesity prevention is to the Texas Department of State Health Services, and that you also heard a brief mention of our support of the Texas School Physical Activity and Nutrition Project, or Texas SPAN. And so I'm excited to now go into a little bit more detail about the importance of this topic to our agency's Title V program and the work that we're doing with the Texas SPAN project. So just to kind of give us an overview of what we are and what we do in Title V. So since 1935, the Social Security Act has provided funding for the Title V Maternal and Child Health Block Grant Program. And it is one of the largest, oldest, and longest running federal block grant programs in the country. And it is funded by HRSA, the Human Resources and Services Administration. And the general purpose of the Title V MCH Services Block Grant Program is to create that federal and state partnership in order to develop systems that meet the challenges of our maternal and child health populations within each of our states and jurisdictions. And some of those challenges can include, but are not limited to, providing comprehensive care to women before, during, and after pregnancy and childbirth. Providing preventative and primary care services for children and adolescents and those with special health care needs, preventing injury and violence, and also meeting the nutritional and developmental needs of mothers, children, and families. Next slide, please. So with this, a bit about our structure. So each state and jurisdiction conducts a comprehensive statewide needs assessment every 5 years. And this assessment helps states to determine what type of health priorities there are across the state, looking at a bunch of different stakeholders and input. And it helps us to target our funds to address certain priorities within the maternal and child health populations, and then to set benchmarks with which we report on annually to our federal funders, and to really highlight the progress that we have made in making an impact on those health priorities. And then states also develop a 5-year state action plan that describes proven methods and measures to address those priorities and meet their unique needs. And so one of our strategies, as I'll go into more in a little bit, is the Texas SPAN project. Next slide. So obesity prevention for the past several 5-year cycles has been identified as a priority amongst numerous stakeholders across the state through our needs assessment process. And this led to the creation of a state performance measure, which is focusing on the reduction of the prevalence of overweight and obesity in Texas children ages 2 to 21. And one of our primary ways to make an impact is to fund and support the Texas SPAN project. We know that we can't address issues that we don't know much about. So really the SPAN data provides an important foundational piece for us to understand what the landscape of childhood obesity looks like, so we know exactly where we should be focusing our efforts. Next slide. So SPAN data provides a representative snapshot of the weight status and related behaviors that is used by DSHS to track trends, identify emerging issues, and generate benchmarks that we use within our Title V block grants reporting. And really having this clear image of childhood obesity landscape is really critical in ensuring that our work makes the right impact as we are implementing these different strategies. Next slide, sorry. And then finally, just providing a few examples of how we put SPAN data to use within our Title V program. So SPAN is the data source to track prevalence of overweight and obesity progress in Texas children as it relates to the state performance measure I previously mentioned. SPAN data is a representative state level source for obesity metrics to identify gaps in opportunities during our Title V 5-year needs assessment that I mentioned earlier. And these data inform application-based opportunities that might require health issue evidence, such as grant proposals and applications to various collaborative programs. Different areas of DSHS, like the Maternal and Child Health Epidemiology Unit, use and analyze these data in numerous reports and publications. And the SPAN data is shared with public regional health staff as a supplemental aid to inform obesity prevention work that they are conducting regionally. So with that, I will now pass it over to Dr. Hoelscher, who will share more about SPAN and other ways to turn data into action.
Thank you, Claire. That was a great introduction to the SPAN project. So I'd like to kind of take what Claire has said and kind of go a little further with it on how we translate this state level data into public health impact. So to begin with the next slide, I'd like to share a quote with you. And I think it's appropriate because Mike Schmoker is a former school administrator, English teacher, and football coach, and he's authored books called Focus that are widely used in the school population. And so, as Claire alluded to, things get done only if data we gather can inform and inspire those in a position to make a difference. So unlike these data are not like the screening data, the school level screening data that we heard about previously. These are used to get a statewide picture of what's happening in SPAN, but unless we can use the data in an effective way, you don't really want to collect data and not have it used. Next slide, please. So a little bit about Texas SPAN. It's a partnership between DSHS and the Michael and Susan Dell Center for Healthy Living, as you've heard. You also heard that we monitor the prevalence of and secular trends in health-related factors in school children in Texas. And so that includes body size, diet, and physical activity. In 2019-2020, we conducted SPAN for the 5th time statewide. However, as many other things, we got interrupted by the COVID-19 pandemic in March 2020. So we have a smaller sample than we've had in previous years. However, we still were able to calculate statewide and Texas-Mexico border, non-border sampling weights. And currently, we are conducting SPAN 2022-2023. So that's underway with measurements right now. Next slide, please. So before I go any further, I'd just like to acknowledge our SPAN research team. It takes a lot of data collectors and project coordinators to make this all happen. And we use local folks across the state to collect SPAN data. Next slide. I'd also like to acknowledge our help from Department of State Health Services and our funding from them, as well as many partners. So as you can see, we have partners across the state that help us conduct this. Next slide. So a little bit about SPAN by the numbers. To date, we've had almost 80,000 students participate across all 5 panels of SPAN. If you look at the number of schools that have participated, it's over 1,500. If you look at the number of individual schools, some have participated in more than one SPAN. It's more like 1,200. And then if you look at the number of publications, we've had 41 publications, some of which are very highly cited. The number of students who participated in our last round of SPAN in 2019-2020 was over 8,000. So it's a large sample size, and then we weight it to represent the Texas population. Next slide, please. So here's an overview of the previous SPAN surveys. A few things I want to point out is we added 2nd grade in 2015-2016. Prior to that, and for all years, we've surveyed 4th, 8th, and 11th grade. And that's to represent elementary, middle, and high school are roughly developmental levels of children, pre-puberty, peri-puberty, and then post-puberty. One of the unique factors about SPAN 2019-2020 as well that I didn't mention is we have data right up until when the pandemic began. With our current round of data, we'll be able to look at data once the pandemic ends and kind of see where we were prior to that and then what's happened in the ensuing years. In addition to measuring the kids, we also measure several school level factors. So that has everything from campus improvement plans to a school health policy survey to doing vending machine audits and healthy signage. Next slide. So the data that are collected during SPAN include a directly measured height and weight. So we vary from some surveys such as the YRBS, which asks for self-reported height and weight. We directly measure that and then have quality control measures in place. We also have a self-report questionnaire that's administered to students of 4th, 8th, and 11th grades. This questionnaire has been validated and assesses demographics, dietary intake, physical activity, and sedentary activity practices, knowledge, and oral health. And for the 2nd graders, they're not old enough to complete their own survey, so we have a take-home survey for their parents, and that has similar constructs to what we measured in the 4th, 8th, and 11th grade. And then finally, we measure school policies and practices, and I mentioned some of those previously. Next slide. So just to show you what kind of data we get from SPAN, I'd like to show you the trends in child obesity in Texas. And this is from 2000 to 2020. So this includes all 5 panels of our SPAN administration. So if you look at grade 4, what you see is a parabolic curve. So it actually decreased and then it's gone up again in the ensuing years. So in between 2000 and 2004, there were a lot of state level policies enacted, including the implementation of coordinated school health. There were initiatives that happened in terms of the Texas Public School Nutrition Policy. And together, all of these seem to show an effect in decreasing the prevalence of child obesity in 4th grade. So a lot of those initiatives at the time were geared toward elementary school children. This level was maintained to 2009, 2011, but then we started to see the prevalence go up. And during that time, there was a lot of backsliding on some of the legislation. Some of the accountability wasn't as strong as what had happened in the past. If you look at grade 8, which is in the green line, and then grade 11, which is in the blue line, you see a gradual increase in the prevalence of obesity over time. If you could advance the slide. Yes, there we go. For Healthy People 2030, which is the health goals of the nation, you can see that the goal is 15.5% prevalence of obesity among children. And what you can see is we're far above that currently. If you advance the slide again, you should see another line come up, and this is what NHANES measured in 2017, 2018. So that's the most recent data we have on a national standpoint. And at 19.3%, it is higher than the Healthy People 2030 goal. But if you look at our Texas children, the prevalence of obesity is above that even. So another thing that was pointed out in the first presentation today was severe obesity among adults. So if we could advance to the next slide, you'll see the prevalence of children with severe obesity in Texas. So as you can see, this is definitely a concern here. If you look at the national prevalence of severe obesity among children from 2 to 19 years, as measured by NHANES, it's currently at 6.1%. And so if you look at 2nd through 11th grade, what we've collected here in SPAN, you can see that it's well above that for all grade levels. So that certainly is a concern to us, as we know that obesity levels track as children grow. Next slide. In addition to measuring obesity and overweight, the SPAN survey also provides data on dietary intake and physical activity and oral health, as I mentioned previously. So this is just an example of some of the data that we get from SPAN, and this particular slide highlights the number of times that sweet and savory snacks were consumed per day by grade level. So these are computed as consumption of candy, frozen desserts, ice cream, popsicles, things like that, cakes, cookies, French fries, chips, and snack bars, so granola bars and similar items. And as you look at this, you can see that a large percentage of children consume these foods. 40% of children in each grade level or more consume these foods 3 or more times a day. So that certainly is a concern for us, especially when fruit and vegetable intake was lower in this group of school children. Next slide. So just a little bit about, now that we have these data, what do we do with them? So this is a model of promoting evidence uptake in schools. So it's really a model of how you disseminate data and put it into action. So if you could advance the slide, when we do the SPAN data collection, we're over into the area, the key research areas. So you start asking, what is the prevalence of obesity? How many children are consuming fruits and vegetables? How many children are engaged in physical activity? So you generate and source the data. And so that kind of corresponds with the level of SPAN data collection. So the next, part of this has to do with synthesis of the data. And so this is where we generate the SPAN analyses. So we're able to kind of look at these and take the data that's collected and say, well, what does this mean? Then the next level is utilization. So during utilization, what we have done is develop our research to policy collaborative materials. So this is where we apply recommendations and talk about comparatively where we are. And then the last part of this is sharing our RPC materials. So it's knowledge management, which has to do with translation and dissemination of the data to decision makers. So in the next slide, we're going to talk about evidence-based tools and resources and how we use them. So the next slide describes our Texas Research to Policy collaboration. So in this project, we are trying to improve the health of Texans through policy making, especially when we're assisting legislators to use Texas research data and see us as trusted resources. So in this, we're engaging state and local stakeholders in capacity building. So as part of that, we've recruited a nonpartisan network of health researchers across the state that we used in the 2021 Texas legislative session as experts, and we hope to use the same model in the 2023 legislative session. And then finally, as part of the Texas Research Policy Collaboration, our RPC, we want to respond to state legislative requests. So if they need data, we would like to provide that and also provide recommendations and assistance in data-driven policies for health. Next slide. So just a little bit about what we did from June 2020 to September 2021. We developed and disseminated health policy resources to state legislators and their staff. So these were developed, as I mentioned before, by our staff in collaboration with the network researchers. So they included a series of health policy reports that were based on legislative requests and policy priorities. So we asked the legislators first, what health issues are you interested in? And then we addressed them by using our data. And then we also posted resources on our webpage and distributed those by email and a newsletter. Next slide. So a main part of the information that we provided to legislators were our Texas Child Health Status reports. And so we have a title for these of Healthy Children, Healthy State. And so what we did was we translated public health research into policy and practice using the data that we had collected during SPAN. So what these are brief, concise reports that really highlight some of the data that we found by conducting the last SPAN. We also did these in collaboration with a network of researchers, so they were very well reviewed. And we really highlighted issues that were actionable in terms of policy options. Next slide. So up to March 1st, this week, we have released 11 reports as part of these Texas Child Health Status reports. So most of these are derived from SPAN data. There are 3 that are about vaping and e-cigarette prevention that we have used our data from our Tatum study here at the center. But the majority of these reports have been based on SPAN data. Next slide. In addition to that, we have made Texas SPAN data available to anyone who wants to use it through our Texas SPAN Data Explorer. So here you can see the data by the different levels. So we have it at the state level. We had every year except 2019 to 2020 by public health regions. And then we also look at it by the Texas-Mexico border versus non-border regions. So that's a unique feature of our data. If you go into the SPAN Data Explorer right now, it's showing 2015, 2016 data, and we're updating it with more current data within the next couple of months. So here's an example of a report that you could pull out from it. So you can look at diet, physical activity, sedentary behaviors, and then health status as well. Next slide. So to show you the reach of our Texas Health Status Reports, this is a report of clicks or uses or views of these resources from February 2019 to February 2020. And so the Child Obesity Report was released first in February of 2019. And as you can see, it's had the most views to date with 965 unique views. One other thing to notice is every time we release one of these, we send an email to our contacts. So initially we had sent it to over 5,000 contacts. If you look at the bottom at the breakfast consumption, you can see that our list has grown to over 13,000 contacts. And then we also have the open rate here. So you can see that the child health status reports that were most frequently, that were opened at a higher percentage were the child sugar sweetened beverage consumption report, and then our breakfast consumption, which was recently released, and it had a 30% open rate. So this is actually above the industry standard. So we can see that these are getting distributed, they are being viewed, which is good news for dissemination of these data. Next slide. So in addition to providing data, you have to provide actionable steps as well. So as part of this, we've developed 3 toolkits. And so these toolkits accompany the Texas Child Health Status Reports. So they are focused on providing information and actionable steps. And we draw on many of our partners for materials to include in this. So for example, for child nutrition, there are links to Texas Department of Agriculture and some of the initiatives and the good work that they've done. We also draw in evidence-based resources and best practices. So we try and provide tools and guides that can be used by community members. Next slide. So in summary, we know that community level stakeholders and state legislators need these local data and resources to create evidence-based policies. So these Texas Child Health Status Reports are one way that we can provide tools for this. So, so far we feel that it is becoming more of an effective model to provide accessible child health research for policymakers and other stakeholders in Texas. And one of the things we've learned is collaboration is a key factor. So our recommendations as part of this work are that it's really important to translate these key research and surveillance findings into usable, easy to read, and digestible formats. If you get a bunch of data in front of you without an interpretation, it's kind of difficult to determine exactly what they mean. So tools such as this Texas Child Health Status Report are resources that are easily accessible. And we really encourage you to look at these and use these to support evidence-based policies in the community. And finally, with these tools, it's important to get feedback from the community and policymakers on these. What do they need data on? What topics do they need data on? What do they need to make informed decisions? And we can go about getting what we have or finding other data sources and putting them together into where they really make a difference. So we really want to decrease the amount of time that research gets into practice. Currently, it's around 15 to 17 years, and we'd like to make it a lot shorter than that. So that's the whole aim of translating the data into actionable steps. So thank you very much. The next slide just details the research team that has worked on Texas RPC, and then the next slide shows links to our various resources that we've developed. So Emily, I'll turn it over to you.
Thank you. We just, it looks like we just have one question. It looks like we can sneak one in here. It says, if groups or individuals begin to engage elected officials before the session begins, which of the resources that you've provided would be most effective to highlight in the meeting with them?
I think really any of these would be effective to highlight. I think the child obesity data is pretty compelling. So I think that that's an important one. I know another one that's important that we've looked at quite a bit, and I know that several groups here have been interested in, is physical activity levels in the schools. So that one might be another one that I think that there's some very actionable policy level steps that can be taken. I know that PE has been kind of sporadic during the past year, and we've heard other people say that as well. But that's an area where I think you can make a difference.
Okay, excellent. Well, thank you for sharing this wonderful resource with us, and thanks to the Susan and Michael Dell Foundation for their support in co-hosting this summit. And thank you everyone for attending the summit today and for helping us commemorate World Obesity Day in 2022. That concludes.
Thank you, everyone.
Thank you.